Oh, good morning.
Morning.
Hello.
Morgan.
Good morning.
How we all doing?
Morning.
Good.
Good. Good. Okay. Let's
Definitely am.
get all up into that respiratory system. So we left off at PAH, right? Going into pulmonary
Pulmonary
embolism.
embolism.
Oh, sorry. I thought we were fine. No, ask me where we were. This one. A couple slides. Any questions or anything before we get started? Oh, because this isn't this week's attendance. Thank you. Okay, I'm hoping if I do it through Google, like Docs, it's not going to skip ahead on me by itself. It did. Okay, because that was super annoying. Okay. Okay. So let's get into PEs. What is a PE? Pulmonary embolism. What does that mean?
Blood clot in the
Yeah.
lungs.
In my lungs. No good. They could be small, they could be micro, they could be like scattered, or it could be big on one side. It could be big on one side that goes over into the other side. We call that a saddle PE because they think about it like a horse saddle where it goes from one side to the other. Okay. So instead of saying like, I mean, unless you had clots in different places on both lungs, that would then be a bilateral PE. But when it's connected from one side to the other, it's a saddle PE. So a pulmonary embolism is a blood clot that blocks a blood vessel in the lungs, usually the pulmonary artery, and obstruction of blood flow. So, and remember, the lungs is the only place where the artery and veins are opposite, right? So the pulmonary artery takes blood from the heart into the lungs to get oxygenated. And then the pulmonary vein takes it from the lungs back to the heart with oxygenated blood. Okay, so it's the opposite way. So your risk factors are going to be really, it's the same for any blood clotting at all. So recent surgery, arrhythmias, specifically AFib and A-flutter, obesity, smoking, absolutely. What just happened? Why did my TV turn on? Come back to me. Especially oral contraceptives. And by the way, if you put oral contraceptives plus smoking, we're at an even higher risk. Oral contraceptives plus smoking plus obesity puts you at a high, that's a triple risk, right? Plus older than 35. So we think that young people aren't going to be at a super high risk, but when you add all of those things together, it increases the risk. Sorry, my TV just like literally stopped working all of a sudden. Okay. Okay. So when you put all of those things together, your risk gets extremely high. Also immobility, long bone fractures, so femur fractures, especially the femur. The femur is extremely vascular. When we have long bones, we have a lot of bone marrow, and oh, that it's because of that thing. That thing shut off. The stupid thingy over there. This is why I record from here and I talk through here and I don't talk through there because that thing sucks. Sorry, I'm just trying to reconnect my thingy. I'm sorry for being distracting. Oh, I put fours. Now we're back. Okay, so sorry about that. Okay, so again, long bone fractures, especially fractures of bones that have a lot of bone marrow and are very vascular, they're responsible for red blood cell production. And also along your femoral bones, you also have your femoral artery. So sometimes when you have a femoral fracture, it can affect the femoral artery. And then you have an excessive amount of bleeding. And then when you bleed, you clot. And any clot coming from anywhere can travel to the lungs, can travel to the heart, can travel to your brain. So patients that have previous clotting should be on anticoagulants for the rest of their lives, really. And especially if they have risk factors like arrhythmias, like AFib, A-flutter, they should always be on an anticoagulant to reduce the risk um, of clotting. So the most common cause is from a DVT. And this is when the blood clot forms in one of your lower extremities. It gets dislodged, travels up to the vascular system, and then becomes lodged in the lungs. So when this happens, it impairs the circulation within the lungs, which then impairs gas exchange because we need that circulation through the capillary membranes right next to the old alveoli to have that gas exchange. If something's blocking it, there's no gas exchange. Okay. So your symptoms of a PE, really one of your very first symptoms, because most PEs are pretty stable, to be honest. Most PEs, your patient comes in and they're like, man, I just feel really short of breath. Like, I don't know what's going on, but all of a sudden, not really all of a sudden, but like progressively or suddenly, I can't catch my breath. When a PE gets really bad, that's when they have that really intense anxiety and that feeling of impending doom. We've talked about that multiple times. That feeling of impending doom is so real. It is so legit. If your patient looks at you and has that intense, I am going to die, something is going to happen to me, I'm telling you, something is happening, you should listen. Okay. Tachycardia, because the heart is working harder for cardiac output, for oxygenation. It all comes back to oxygenation. Tachypnea, because we need to breathe faster to get more oxygen, for more blood flow, to get more oxygenation. Chest pain with inspiration. And this is, you're just trying so hard to get that air in. And that can cause pain within that tissue. Hypotension, diaphoresis, and then a sudden change in level of consciousness. This is going to be your late signs, your hypotension, diaphoresis, and sudden change in level of consciousness. This is when stuff's getting real. Your patient is becoming extremely symptomatic. And at this point, hypoxic. Okay. So diagnostics is going to include a CT scan, a D-dimer. So this has it as 0.5. Some hospital systems are in, so this would be grams. Some hospital systems are in milligrams. So I was always taught that a D-dimer over 500 is positive for a blood clot somewhere, something's going on. So if we're talking about milligrams, it would be in the 500 range, over 500. If we're talking about grams like this, it would be 0.5, over 0.5. Okay. And also on Monday, we talked about something called a VQ scan. A VQ scan is also diagnostic of a PE. Okay. We talked a VQ scan. It stands for, well, you would think there was something with a Q, but it's actually not. It's ventilation perfusion scan, but for some reason they call it a VQ scan. Okay.
So if it's above 0.5, that means
That's the D-dimer. If a D-dimer, which is a blood draw, so that's a lab test. If your D-dimer is greater than 0.5 or greater than 500 milligrams, then you would be positive for a clot somewhere.
Mine was 900, and they told me that was normal. Like
That is not normal. That is not normal. A D-dimer of 900 is not normal.
Yeah, they were like, I think I might even still have it in my lab work, but they said it was normal. I was
when
like,
I had my DVT and my PE, they did a D-dimer on me. They're like, oh, it could be elevated if you're sick too.
So it's not extremely diagnostic. When we're talking about D-dimers, you can, and that's why you should always have follow-up diagnostics. A D-dimer by itself is not 100% diagnostic of a clot. It's indicative of a clot. It can be elevated for other reasons, which is why we have other diagnostics where we can actually visualize in the CT. It would be a CT angiography, because remember, angiography is how we assess the arteries. So when we were talking, and I can't say that because we can't talk about the test.
Everybody ain't taking it?
They're taking it after class today.
Oh.
So we also have what's called a VQ scan, which stands for ventilation perfusion scan. This is a 2-part nuclear medicine test that assesses the airflow, which is your ventilation part, and blood flow, which is your perfusion part, in the lungs. It is primarily used to detect PEs or other issues like COPD. So it involves breathing a radioactive gas and receiving a radioactive tracer injection. And then it's followed by imaging with a special camera to see how the air and blood move through your lungs. Sounds very cool. I've never actually seen one. My patients just kind of go to them and then they come back. I've never had the opportunity to actually see it with my own eyes, and reading about it, it sounds pretty cool. And to be honest, I don't know how I would feel about breathing in radioactive air. Personally, I don't know how I feel about that. But if I had a pee, I would probably, do what I had to do. But without having a pee, it makes me feel a little uncomfortable. So, but I do want you to know what a VQ scan is. A ventilation perfusion scan is used for diagnostics for a PE. Okay. So please write that down. So for treatment, we have anticoagulation therapy, preventing the clot from getting bigger and formation of new clots. Remember, anticoagulants and thrombolytics are 2 completely different things. Okay. Anticoagulants do not dissolve the clot. It only prevents new clot formation. Because remember, platelets like to do what? Aggregate. So if we already have a clot, the platelets are like, oh, there's a party over here. I want to come stick with you. And then the clot gets bigger and bigger and bigger. Okay. So the point of anticoagulation is that the clot doesn't get bigger. Okay. So then we have thrombolytics, which then dissolve the clot. So there's a difference, big, fat difference. And also when we're talking about thrombolytics, we have a lot of contraindications. Okay. So when we're talking about thrombolytics, we're talking about TPA, TNK, what we give for thrombolytic strokes if the patient is a candidate. So this is the same thing we're talking about, and we're talking about the same thrombolytics when we talked about an MI. It's the same drug. Okay, so the contraindications are the same for every single disease process. It doesn't matter the disease. If you're getting a thrombolytic, if it is contraindicated for that patient, they ain't getting it. Okay. A procedure, we can have a thrombectomy, which is when they go in and actually remove the clot. There are some pretty amazing pictures out there of the removal of saddle PEs that will just blow your mind. I mean, it shows the entire vascularity of the lung tissue in one clot.
The tech that I sat in for the heart cath, because that's what she was doing. She was getting thrombolytic.
Yeah.
They were telling me about a saddle
PE.
but
Yeah.
she did not have one. She just had smaller ones, but
Smaller
they were
clots.
telling us about the new product that they were using. So there was a man there who brought it, where they go in with the original catheter and then they go in with the larger one and they attach to low suction and
they suck it out.
Suck it out, yeah.
It's very cool. Very cool. The thrombectomy is dangerous though, right? Because I don't know if you've ever touched a blood clot, but I mean, we've all seen them, right? I mean, we're all women. We've seen them, okay? They're squishy. They're fibrous. I guess it's not super easy to break it apart, but if you went in with like a metal chomper to try to like grab it, it's gonna break apart, right? So any dislodgement of any part of that clot that you aren't physically removing and being free through the vascular system travels. It is going to travel.
That's what happened
Okay.
with my DVT. It started in my leg and then it broke off and I had multiple both sides.
Yes, that's exactly what I'm talking about. So she's saying that's what happened with her DVT is when she had a DVT, a piece broke off and traveled. And you had PEs, I'm assuming.
Both sides.
Bilateral PEs. So That is the main form of origination. It can happen from anywhere, but it's most commonly from a DVT. So then we have an IVC filter, which stops the clot from traveling to the lung. An IVC filter is specifically for people that cannot take anticoagulants. Okay. So an IVC filter can be used for anyone that has a high risk of clotting that cannot take anticoagulants. Okay. And it's usually put in through the femoral artery because it's the biggest one. Well, I mean, other than obviously the vena cava.
IVC filter.
IVC filter. It's literally like a net. Like they go in through the artery and they open it and it opens into like almost like a strainer. Okay. So blood can go through the strainer,
Big clot.
but anything that's big cannot pass through.
That's the thing that kind of looks like an umbrella.
It kind of does look like an umbrella. Yes, absolutely. So this, not everyone, I mean, we would rather put you on an anticoagulant if you are a candidate for anticoagulation.
I had to find a picture of a pulmonary.
It's pretty sweet, isn't it? She said I had to find a picture of that saddle PE and she said it's, oh, it's just a PE. Yes, it's so cool. If you have a chance, please look it up. It's very, very cool.
That here.
Another thing I want to talk about that isn't talked about on this slide is called an EKOS catheter.
Equals?
Yeah, I think it's EKOS. Yeah, EKOS. It stands for Ecosonic. So an EKOS catheter system is a minimally invasive medical device that uses targeted ultrasound waves combined with thrombolytics to dissolve dangerous blood clots, primarily in the lungs or legs. What I find interesting is that every time I have ever had an EKOS catheter for a patient, my patient was on heparin. The EKOS catheter ran with heparin. Heparin is not a thrombolytic. So I find it interesting that my experience with EKOS was with heparin, and now that I'm looking it up, they're saying it's with thrombolytics. So I wonder if there's kind of two ways of doing it. With heparin. Okay, so EKOS endovascular system uses ultrasound facilitated catheter directed thrombolysis to treat blood clots by delivering lytic agents. So it includes thrombolytics and heparinized saline. Heparinized saline is often used as a coolant or flush to maintain catheter patency and prevent pericatheter thrombosis. Interesting.
Removes or dissolves.
So you know what's really interesting, and this is where the education is crazy, is that I, as a nurse on the floor in the ICU, had patients with EKOS catheters, but nobody ever said to me, hey, this patient's receiving a thrombolytic. The patient was on bed rest. You have to be on bed rest when you're on an EKOS catheter because it runs for like 24 hours. And I knew that it had heparin because I was hanging heparin, but nobody ever said to me, hey, Jess, this patient's also received a thrombolytic. Now I feel dumb. So anyways, an EKOS catheter system uses ultrasound waves to break things up. Remember when we talked about like renal stones and lithotripsy, they use that ultrasonic, whatever to break up the renal stones, the stones. So this is it's kind of the same idea, but obviously different because it's cardiac. But it's the same idea of kind of breaking them up, busting them up, and then that it makes sense. The thrombolytic is then dissolving them. Okay. So obviously for someone with an EKOS catheter, they would have to be a candidate for thrombolytics. Okay. So nursing interventions, we want to make sure we monitor our vital signs, our respiratory status, anticoagulation and thrombolytic therapy, signs of excessive bleeding. So any signs of bleeding, bleeding gums, excessive bruising, petechiae, GI bleed, coffee ground emesis, what else? Hematuria, bloody nose. Okay, these are all signs of thrombocytopenia, decreased platelets. Okay. Oxygenation, we want to administer oxygen as needed, reposition frequently to promote gas exchange, elevate the head of the bed for maximum lung expansion. And then after that, we talked about when you have had a DVT, you are going to be on DVT prophylaxis for the rest of your life. So when we talk about DVT prevention, we're talking about early ambulation. Woo, did it just skip? Oh, no, it didn't. Range of motion exercises if the patient is immobile. So if your patient is in the ICU, intubated, sedated, whatever, or they're completely bedbound, we need to be doing range of motion exercises at least once per shift. Okay, at least. Compression stockings, if possible, SCDs in the hospital, and avoid crossing the legs. This is a huge thing, especially for patients that are like post-op knees and hips, specifically hips. You never want to cross your legs when you have a brand new hip. But my mother-in-law, she drove me crazy. She got a new knee last year, and I swear every time I turn around, she's got her legs crossed. Like, Mary, stop. Stop. She don't listen. Bleeding precautions, we want to use a soft toothbrush only, okay? Because, you know, the bleeding gums. Electric razors. I don't remember what class it was. And I don't remember if it was last term, if it was advanced form. I don't remember. But I had a question on my exam about bleeding precautions and razor use. And there were multiple people that said that using an electric razor was contraindicated, that they could not use it. I'm like, guys, that's the safest way. I'm like, what do you mean? So that was super frustrating for me because I'm like, this is something that should have been taught in foundations. I mean, even when you're a tech on the floor, you know, we're not handing out razors to men that want to shave their face, especially older men, or women that want to shave their legs. We're not just handing out razor blades, okay? And the reason is because if they're on anticoagulation, we don't want them cutting themselves. We use electric razors for a reason. So put that in your back pocket, okay? In your filing cabinet. Don't forget it. Do not take aspirin while you're taking other anticoagulants or thrombolytics. And then, of course, we want to avoid falls. We don't want our patients falling all over the place, which is why when a patient receives thrombolytics, if a patient is on an ECOS catheter, they have strict bed rest. Okay. Any questions about PEs? No, I don't know. You don't have to know about the ECOS catheter for the exam. Really, the only thing that I want you to know probably for the exam is about the bed rest when receiving any type of thrombolytic therapy. But really, the ECOS, you're going to see this in your nursing practice. Like eventually, at some point, if you ever get pulled to tele, if you ever get pulled to step down, if you work step down, if you work critical care, maybe even in the ER, you may see an ECOS catheter. So I don't want you to see it and be like, what the is this? I've never seen this, I've never heard this word in my life. Okay. And apparently, oh, it skipped it. The next one on my paper is end of day 1. Like, oh, well, apparently we're done. We're done. So next is chest trauma. This is going to be a really big part of your exam. ABGs are going to be a big part of your exam. ARDS, acute respiratory failure, chest trauma, and chest tubes are going to be huge. Okay. So chest trauma is injuries to the chest that are often life-threatening that result in hypoxemia, resulting from the disruption of the airway, of course, and then hypovolemia, which is massive fluid loss, most likely from bleeding. Okay. So blunt trauma is 53% of traumatic deaths, and that includes motor vehicle accidents, falls, any traumatic event that can happen to the chest. Acceleration, moving objects hitting the chest. Remember inertia? We learned about it in like middle school. So
Barely.
she said barely. So inertia is when something hits at a high speed, it stops, but the contents inside continue moving. Okay? So when you hit, specifically, I wrecked my car, I totaled my car when I was 17. I got in a head-on collision. It was super scary. They had to cut off all 4 of my doors and my roof to get us out. And neither of us had our seatbelts on. It was super scary.
I always tell my kid that, like, if the car's moving 60, so is your face.
Yes.
So go through that one. So is your face.
So when I hit head on, my first instinct, because I knew it was happening, was to throw my arms in front of my face. And then my airbag went off and I had burns down my arms and I had burns on my chest. And I even have, like, if you look really closely, you can see a scar on my chest from the airbag. And when it happened, my car, they hit each other and my car flew back. Both cars like boing and like bounced off of each other. And my very first memory is this guy came out of nowhere. Is this person real? Was it an angel? I literally don't know. I have no idea.
Your guardian angel.
But someone came and he said, I live across the street. I watched it all happen. He grabbed my head and he said, everything's going to be okay. Don't move. The ambulance is on their way. And that was my first memory after my wreck. And I have no idea who that person was. So anyways, the ambulance gets there and I'm sitting there and my friend Valerie is next to me. And I just remember saying to the paramedics, I'm like, get her off of me. I can't breathe. Like, I feel like I can't breathe. I was convinced that she was on top, like she was sitting on my chest. And really her head was on my lap. She was like in between my center console and she was like laying on my lap. But the force of us hitting and then the airbag hitting me and shoving me back, everything inside of me kept going forward. And it was this crushing sensation in my chest that I could not breathe. So when we're talking about chest trauma and that act of inertia, is that remember when you're falling or when you're hitting something, you hit that brick wall and everything inside of you is still moving. And it hits your chest wall at the same speed that you were going. And it hurts. I was fine, by the way. Thank God. I spent one night in the hospital. It's okay.
Is Valerie still your friend?
No, she's not still my friend. She was a very bad influence. By the way, this was the very first time in my entire life. What'd she say? Can you let Toy back? She's not in my waiting room. Oh, maybe it's over here. Straight up. So, yeah. Oh, it was the very first and only time I ever skipped school. October 29th. At 8:30, 9:30 in the morning, I was going to the Struthers courthouse to pick up a girl that I was not allowed to hang out with, by the way. I was not allowed to hang out with her. By the way, she was at the Struthers courthouse for a reason. Okay? She had court. I was not allowed to hang out with her. I had dropped her off at the courthouse, turned around. We were going down Klingen Road, my people from Niles. I was in Poland going into Struthers. I was going down Klingen Road and she calls me and says, hey, I'm done. I turn around to go back. It was the very first day it snowed, October 29th. My grandma's car.
Oh,
My poor gram, rest in peace, her car. Okay. And Valerie was eating potato chips. And my mom says to me, because they had to break my windshield too. And they covered us with a blanket when they broke my windshield. And when they got us, my mom says to me, she's like, there was this weird stuff, like all in Valerie's hair. It was the chips. It was the chips that like broke and exploded all over her. So anyways,
Did you have music playing?
no, she didn't. I don't remember if I had music playing. But the poor man that I hit, he was 65 years old and I broke his collarbone. But I will tell you that he got a settlement of $35,000 from my insurance company. So you win some, you lose some, okay? I call that a win in his book. So anyways, and that's on trauma. So acceleration, deceleration, shearing. This is when there's a rupture of arteries, veins in the lungs that when my brain can't even think anymore. And then compression, which is a direct blow to the chest. So you have blunt trauma that does not actually penetrate. There's nothing open. So when you have bleeding of blunt trauma, it's all contained inside. This is when we get a hemothorax, okay? And then penetrating trauma is classified by the velocity of the injury. And this is when something is actually penetrating the chest wall. So a gunshot, a stab wound. God forbid you wreck your car and a pole goes through your chest, right? A penetrating chest wound. By the way, if you ever have penetration, do we remove it?
No.
We never remove it. I need lead in. I need to,
They're like an automatic.
I know, I wish I could. Probably not, because I want you to be able to like control.
Every other one, we didn't have to get like let in, it just automatically went through.
I think it's because it has a password. I don't know actually. But if you think about it, when we do test reviews and we're one-on-one, and then I have someone like waiting to be let in, that's a good thing. I don't want them to just walk in on our test review. You know what I mean? So it's a catch-22, I guess. So anyways. So both of these are going to impair ventilation and perfusion. They could lead to acute respiratory failure, especially if you collapse a lung or you have a hemo or pneumothorax leading to a collapsed lung, and then if you have a lot of bleeding, this can then lead to shock and then eventual death if not treated appropriately. So super scary. And we're going to talk about trauma next week. So chest tubes. There are two different types of chest tubes. We have wet suction and we have dry suction. So this is a tube that is inserted into the pleural space, the space between the chest and the chest wall and the lungs. So in the pleural cavity, who did I draw that picture for yesterday?
Me.
Okay. So if you think about the chest wall or the thoracic cavity, then you have the lungs, and around the lungs, you have the pleural sac, right? Every organ system has their own sac. We have the peritoneal sac, the pericardial sac, we have a pleural sac. So when you have a hemothorax or pneumothorax or pleural effusion, this happens within that sac, okay? That surrounds the lung. So a chest tube is to drain fluid or air to relieve pressure and to re-expand a collapsed lung. It is inserted into the fourth or fifth intercostal space. On the side, it's always going to be axillary. It's never going to be in the front. It's always going to be axillary. And there's two main types, which I just said. So wet suction, dry suction. What is the difference? Wet suction, the suction is regulated by the height of the column of water, okay? Both have collection chamber and water seal, and the suction, I can't even see that, it's so small. Suction control differs. That's what it says. That's better. So with a wet suction, we have a water suction regulator. We have a water seal chamber, which if you'll notice, they both have a water seal chamber. This end connects to the patient. And then you have 3 columns, usually 3 columns. And that is your collection chamber. Okay. So with the wet suction, you want to monitor the water level. The water will be appropriate and needs to be refilled. We only ever refill water. Okay.
They had one of these in the room, at the UH, and Maria was explaining it to us.
She was explaining the chest tube.
Yeah, just like showing us the kind of the way they work.
Yeah. And it's different for each, though, the wet versus dry. So dry suction, the suction regulated is by the suction control dial. So wet suction, it's regulated by the water. So the higher the water or the lower the water is going to change your suction level, which is very important because the control of the suction is super important for the patient and patient safety. You don't want really intense suctioning in someone's chest wall. Okay. So for dry suction, you have a suction control dial, you have a suction monitor, and then you have an air leak monitor. And then this, just like the other one, connects to the patient. And you want to monitor the suction bellows to ensure the suction is working. So that's this part. Okay. They both have the collection chamber. If this falls over, it's going to ruin your eyes and nose. Okay. Because what happens is the first chamber fills. When the first chamber is full, it spills into the second. When the second chamber is full, it spills into the third. If you notice, this starts at 10, that first chamber starts at 10, goes to 200. The second chamber is 300 to 1,000, and the third chamber is 1,200 to 2,000. So if this falls over, and all of a sudden you have milliliter or content liquid in all 3 chambers, it's going to skew your output. So you need to get a new chamber. What helps is it has this little T piece at the bottom, and the canister sits on the floor and the T piece swings out. So it has almost like a Christmas tree stand that it sits on. And sometimes you'll even see the nurse tape it to the floor.
You like, if it's spilled over, you couldn't like just tip it the other way to get it all back to the other side.
No, because then you also have the water seal chamber. It could just screw everything up. You really don't want to be messing with this chamber because it's attached to someone's lungs.
Would you document that it knocked over and you need to restart? Or would just go for
You
the next
could.
chamber or the next container?
She said, would you document that you changed the container? Probably not, to be honest. You could put it in a nursing note, like a progress note. The thing is that is especially important is when you have an extremely high output. And that's why it's so important to monitor this hourly, by the way. We are monitoring this hourly. Okay.
I've seen nurses like tip it, like knock it, like moving around the patient, and they just set it back up.
Yeah, you really should. You really shouldn't. If the output gets screwed up in any way with these chambers, you really should just grab a new one. It's not that deep. It's only that deep when they're putting out a crap ton of fluid. Mm-hmm. Crap. Okay. So, chest tube chambers. We have the drainage chamber. This collects and drains blood into a calibrated chamber in order to measure the amount of drainage. We want to monitor the color and the amount. Okay. So put a big fat star next to that. Monitor color and amount. Sudden bright red blood or drainage of greater than 100 mLs per hour needs to immediately be reported. Most of the time, the people that place chest tubes, it's either going to be your ER physician, and you're not going to report it to them unless you're in the ER, okay? It's cardiothoracic surgery or a surgical resident. So if your patient is on the floor and all of a sudden you see an output of 300 in this past hour and it's bright red, you are immediately calling that surgical resident and saying, you need to get up here right now and assess this chest tube. Okay. A water seal chamber is a one-way valve that allows air to exit the pleural cavity on exhalation, and it prevents air entering on inhalation. Continuous bubbling, put a star on this. Continuous bubbling is abnormal. Bad. It indicates an air leak. Okay. Intermittent bubbling is normal, and it's called tidling. Tidling is up and down movement of water with inhalation and exhalation. This is very, very normal. If tidling stops, it means two things. One, the lung has re-expanded, and that's wonderful. Or it means there's a blockage in the system, and then that's bad. Okay?
So when you know when to panic?
Right, that's what.
Well, that's the thing. Look at your patient. She said, when do I know when to panic?
Oh.
Look at your patient.
I forgot.
Is your patient alive and stable? Is your patient oxygenating adequately, or are they saying, I can't breathe, I'm hypoxic, my chest is in pain, and all of a sudden you have a deviated trachea,
Oh, God.
which is by the way, the cardinal sign of a tension pneumothorax, which you need to know. Tracheal deviation is the cardinal sign of a tension pneumothorax. And then you say, I need help in here. I need a surgical resident right now. Okay. Then you panic. Don't panic.
Please don't.
It's called control panic, controlled panic. The panic is inside, but on the outside, you are calm. A tension pneumothorax. Okay. Suction control chamber. This regulates the amount of suction transmitted to the pleural space. Bubbling in the wet suction is normal. This means that the suction is working. And we're talking about the two different types of chest tube or chest drainage systems. Bubbling in the wet suction drainage system is normal.
When it's intermittent.
Hold on. Remember, when we're talking about the wet suction drainage system, there are two different water places. Okay? You have your water suction regulator and you have your water seal chamber. The water seal chamber is intermittent bubbling, is normal. Water seal chamber is intermittent bubbling, is normal. That's inhaling and exhaling.
Got that part.
The water suction regulator should have continuous bubbling. That is normal. That tells you that the suction is working. So remember, in the wet suction, you have two different water chambers. I know, it's getting crazy. I will tell you that the most commonly used drainage system is the dry suction. That helps you out at all.
For the test, I needed to notice because I was getting confused when it says continuous bubbles.
Right.
Indicates.
That's why I'm getting confused because it says dry suction is abnormal.
I know.
Yeah, can you just repeat?
I'm going to repeat it. Okay. So when we're talking about the wet suction chamber, like you see on this slide, there are two different water chambers. Okay. The water suction regulator, which down here Monitor water level. Water will evaporate and needs to be refilled. The suction is regulated by the height of the column of water in the water suction regulator. This has continuous bubbling. Okay. Both drainage systems have a water seal chamber. Both of them. That is where we check for an air leak. And that is where the intermittent bubbling is normal, in the water seal chamber.
Okay. In
Okay.
both systems, okay.
So when we're talking about suction, because look at this, we're talking about three different things. Over here, we're talking about the drainage chamber, the three drainage columns. Here, we're talking about only the water seal chamber, which is in both. The water seal chamber is in both. And that is telling you that there is an air leak if it has continuous bubbling. Write that down. The water seal chamber is telling you there is a positive leak, which is bad, if there is continuous bubbling. Okay? So intermittent, good. Now over here, we're talking about the suction control chamber. The dry suction, it doesn't have water. There's no water in the suction control because the wet suction has water which it regulates by. The suction is regulated by that water. Okay? So bubbling in the wet suction is normal. Bubbling in dry suction is not normal. Any form of bubbling indicates an air leak in the dry suction. We're not talking about the water. We're not talking about this chamber. We're not talking about the middle chamber. We're only talking about this guy, the suction control. That's the only one we're talking about right now. Does that make sense? Is that better?
Yes.
Are you guys online? Are we okay? Are we following? Yes?
Yes.
Yes.
I believe so.
All right. So nursing interventions, always keep the chest tube below the site of insertion. Same thing with a Foley. You keep the Foley down below the bladder. Same thing with a chest tube. You keep the chest tube below, or the drainage system below the site of insertion. Do not, and by the way, the stripping changes every 10 years, okay? It used to be very common to what we would call milk the tube, which is when you strip the tube and whatever's in the tube, you pull down into the suction chamber, okay? And you're not pulling on the patient, so it doesn't hurt. We talked about this when we talked about JP drains. We talked about milking that tube into the JP drain. So it used to be common that we did this. And then all of a sudden they were like, don't do this. Okay. And then I swear in 20 years, it's probably going to go back. Who knows? I don't know. But they like to flip flop. So, but you should always be a little cautious when someone says to strip the tube, unless you're being told that by the surgeon that placed it. Okay. Unless that is a specific order from that surgeon. Never, ever, ever clamp the tubing. Ever. Unless it is specifically ordered by that surgeon. Okay.
Why would you clamp?
I will never forget. Crazy. I'll never forget this. I had a patient that was transferred from East Liverpool. And he was intubated, sedated, and had a chest tube. When he arrived, he literally looked like he was in an anaphylactic shock. His whole body, his neck, his face, his eyes, every single part of his body was so swollen. It was crazy. And we're like, what is it? Like, we weren't told that he was having any type of reaction or this type of swelling. Like, what is going on? And as soon as you put your hands on the patient, he had what's called crepitus. And it's when air gets trapped in the subcutaneous tissue. And it literally feels like crinkles under the skin, like popping. I don't even know.
Describe it as Rice Krispies.
Like Rice Krispies, yes. Like, you know, if you have a candy wrapper and you rub it together, that's
With
what
dog
it
toys.
feels like in the body. Crazy sensation. I'll never forget it. It was to his head all the way down to his toes.
Dang,
And it was because they clamped the chest tube.
who did it?
Air did it.
I don't know if it was transport. I don't know if it was East Liverpool ED. I have no idea who clamped that chest tube, but they clamped the chest tube and they're lucky that guy survived. And they're lucky he didn't get a tension pneumo. They're very lucky.
What's the other one?
But what was happening was that the air was escaping through the subcutaneous tissue because it had nowhere else to go.
Did they tell him what happened to him?
I have no idea.
Oh.
He did survive.
Is that like the same as like when you crack your knuckles?
Oh, I thought.
Like that popping? Oh, because they say it's like releasing air?
Yeah.
I guess. But no, what I'm saying, that crepitus, you'll never forget. If you ever get a chance to feel it, and if I ever catch a patient like at clinical or one of you guys has a patient that has this, I want every single one of you to feel it because it is a wild sensation to feel this bubbling under the skin. So that is one reason why you never clamp a chest tube. As one very, very good reason why you never clamp a chest tube.
What about when you have to change the chambers? Like you guys said previously about changing the chambers.
Correct.
How do you make sure it doesn't leak and stuff all over?
That's the only reason you clamp it. Okay. So when you're changing that drainage system, you should clamp, change the drainage system, reconnect, and then open it back up. So you should always, every shift, probably even every 4 hours. But you're going in there every hour to check output, right? So you might as well be checking the tubing anyways, and make sure it's not clamped. Okay.
My my patient had a JP and she was feeling around and she called it something else, but I said, is that the crepitus? And she said, yeah, because where it was placed, because she had all her stuff going on, she said sometimes even just around the JP.
You can get air.
It will puff up around.
I'm so glad that you just said that because my brain just went bing. The medical terminology for this word is called subcutaneous emphysema.
That's what she said, yes.
I need to write that down.
It says it. I wrote it down already because I saw it.
Thank you. Because my brain was saying crepitus and I kept saying it in my
Yeah.
brain and then you started talking and I was like, that, okay.
I never heard it.
So because there's lay terms and there's medical terms. We
Right.
all know that. So the medical terminology for this sensation is subcutaneous emphysema. Okay. Encourage the patient to cough and deep breathe often. Make sure they're using their incentive spirometer. We want to monitor lung sounds and the insertion site. Monitor the color and the amount of drainage. Educate to do a Valsalva maneuver when the surgeon, it should not say surgeon, removes the chest tube. Nurses do not remove chest tubes.
What is it called?
Random physicians do not remove chest tubes. It is removed by either a surgical resident or the surgeon overseeing that case. Okay.
At my last clinical, we had to split the chest tube.
I can't hear you.
I said at my last clinical, we had to split the chest tube.
Split it. What do you mean split it?
Yeah.
Between two chambers?
Yeah, so we had to do like it was first one, and then they made us put another one, and then we had to like cut the tube, and then we had to. She did milk it. She said we're not supposed to milk it, but she did milk it, and then we had to like clamp it, and then we had to like zip tie it, and then she had this whole like zip tie device to like cut the zip tie. It was crazy.
It was it
But yeah,
because of increased drainage?
Yeah, I think he wanted to see that if one side was had a larger output than the other.
Interesting.
I think that's
Okay.
the split, but we're at the CVIC, so I don't know.
That's really cool. I'm glad you're having that experience. So when you remove the chest tube, you want the patient to bear down or cough because that engages pressure within the chest wall to make sure that the lung stays reinflated on removal. That brings me to my next point. What happens if a chest tube gets removed by accident? The patient gets up and accidentally steps on the tube. You step on the tube. The wife steps on the tube. The kid steps on the tube. The patient goes to take a step and yank, comes right out.
Those are right there.
What do you do? Well, thanks for reading. But there's more than that. Okay?
Cover it with gauze and tape it on 3 sides.
3 sides. 3 sides. So
Sterile? Is it sterile?
should immediately cover the insertion site with not only just sterile gauze, it really should be
Would it be wet, like,
not wet, like a petroleum based.
oh, okay.
So that air doesn't escape because sterile gauze can have air escape through it.
So,
So
like a
I'm-
zero form?
No, not zero form. Zero
They
form
have
is
the ones for-
sticky. It says petroleum
Yeah.
dressing. It's a petroleum dressing. So you should cover it with a petroleum dressing. And also you should cover it on 3 sides. Okay. We call this a window dressing. And the reason that you do that is because when your patient inhales, it's going to cause that dressing to stick to the side. So because if you leave it open, then the air on the outside, when they inhale, is going to come into their chest cavity. And that is going to cause another pneumothorax.
So you said tape on 3 sides.
Tape on 3 sides. When they exhale, the side that's untaped is a vent. So air that is trying to escape from the pleural cavity
Can come out.
can come out.
Okay.
Yes.
It seems like such an easy fix. Is this like, and this sounds like an emergency, but this fix seems so.
It is very simple. So
Yeah.
that means whenever you have a patient with a chest tube, on your whiteboard, you should have clipped to your whiteboard a petroleum dressing and sterile gauze. You should be ready at any moment to put a dressing on that chest tube if it were to come out at a time where it wasn't supposed to come out.
So do I use the petroleum dressing instead of the sterile gauze?
No, you put the petroleum dressing and then the gauze. Yeah.
Oh, okay, that's why I was confused.
Okay. Somebody wrote something in the chat. At clinical, they also told us to keep 2 hemostats in the room, always with a patient that has a chest tube. That is correct, because if you have to do something with the actual tube. So if it gets connected from the drainage system, something's happening. If you have to clamp anything, you should also keep hemostats. Yeah. So when to notify a physician is when subcutaneous emphysema or crepitus, but I really need you to know the subcutaneous emphysema occurs, which is the popping sensation in the skin that's caused by air creeping into the subcutaneous tissue. It's not supposed to be there. Okay. If you have bright red blood, if we have bright red blood, that means something arterial is happening. And then if you have greater than 100 mLs of output, I don't care what color it is. If it's greater than 100 mLs per hour, you need to notify someone. So again, if the chest tube falls out, immediately cover the insertion site with a petroleum dressing and sterile gauze. If the system gets damaged, you want to insert the tubing into sterile water to maintain the water seal. And this means if you just take that tubing off and you don't clamp it, air from the outside is going to go into the tube and up into the chest cavity, causing an increase in the pneumothorax, right? So you should also have a little bottle of sterile water at the bedside at all times. Something happens to that drainage system, you put the tube in the sterile water. You don't have to clamp it. Okay, because we don't want to clamp it. We don't want to clamp it unless we absolutely have to clamp it. Okay, so when this happens, you put the tube in the water, and when the patient exhales, the air that's coming out bubbles out of the water. But when the patient inhales, they're not inhaling any air from the outside. And that is called a water seal. That's why the drainage systems have a water sealed chamber. Is this making sense?
Yes.
Or am I losing you?
All makes sense. Yeah.
Okay.
Period stuff tuned in.
I want to take a break. I have to pee.
Okay.
Let's take 10 minutes. I was just telling everybody about my Lego addiction, and my husband is building me a Lego building table, and I think I just fell in love with him even more. For Christmas, I love, yeah, and I have them all set up like by my like right in front of my kitchen sink.
That's very impressive that you actually can do that because I don't think I have the concentration to put things together to make something I would give up in the middle of it.
I have really, I mean, you guys have heard me talk about this multiple times. I have terrible ADHD, and my brain is just constantly just running, constantly running. And when I paint, and I'm not a creative person like at all. I cannot even doodle. But when I build things, my brain just goes quiet. And it's just, it lets me just like, because it's the eye and hand or like, what's it called? Eye hand coordination where your brain, your eyes and your hands are engaged, where when, especially if you have an attention disorder, it helps you just like come to one place in peace. So if your kids have ADHD or you're struggling with kids that can't sit still, see if they like to build and like to follow directions, because that hand-eye brain coordination does. Yeah. I found that when we bought our first house, Tiffany said crafting does that for her. When we bought our first house, we had to paint everything. And I love painting. And I'm not talking about like painting a picture. I can't paint. I have no creativity whatsoever. Maybe I could like paint by numbers because I need direction. And I bet you I would like that. But like I can't like imagine something and then build it, or imagine something and draw it or paint it. But the actual act of like painting a wall is very calming for me. Like it just brings me to this like calm.
Little lines, they get all.
I'm like, everybody just leave. Leave me alone. Give me my brush. Give me a bucket. You leave me alone and I'm fine. Okay? Leave me alone. All right. Back to the lungs. So, I did start recording, right?
Yes.
Okay, good. Kaylee said paint by number, crochet and puzzles are my thing. Yes, girl.
Oh, that's
Yes,
for sure.
girl. I'm telling you, it's just so good for your brain. All right. Pneumothorax versus hemothorax. This is going to be very important. It's going to be on your exam. I need you to know the difference, the causes, what you do, and everything about it. Okay? So, a pneumothorax, this is an air leakage into the pleural space. Okay? Your thoracic cavity is meant to be closed. Nothing is supposed to go in there or come out. Okay? So, you have 3 different causes. You have an open pneumo, which air enters into the pleural space from the outside. So something has created an opening, whether it's a gunshot, whether it is stabbing, some type of penetration has occurred. By the way, this can also happen, well, no, I'm not gonna say that. This can happen from anything penetrating the chest wall that is allowing air from the outside to come inside. Okay, go ahead. Yes, we refer to this as a sucking chest wound because it's going to suck the air in from the outside. That's why it's important to cover the chest. If your chest tube comes out, you have to cover it because it's going to suck the air in from the outside. Okay, so you want to place a sterile, that's the word that we were missing, occlusive. That's where the petroleum dressing comes in because petroleum dressings are occlusive. They don't let anything come through. No air at all will come through that petroleum dressing. So a sterile occlusive dressing over a wound taped on 3 sides, which is your window tape, your window taping. Okay. And then it opens from one side. Okay. So it allows air to escape, but it does not allow air to come in when you're inhaling. So it's not going to suck the air from the outside. All right. This treatment is going to prevent a tension pneumothorax. Then we have a closed pneumothorax. This occurs when air enters the pleural space without an outside opening. And this is what I was going to say, where I was like, oh no, I'm not going to say that because I'm going to say it now. This can be caused by a rib fracture. So if you have your ribs are fractured and bones are sharp and you pop the lung and have something stab into that lung space, all of the air that you're breathing into your lungs is going to now seep into the thoracic cavity, causing the lung to collapse and pressure to build up on that side. Okay. So when this happens, the lung collapsing causes so much pressure with every inhalation that the collapsed lung and air start moving into the other side, which is why we see tracheal deviation with a tension pneumothorax. The second characteristic of a tension pneumothorax is a mediastinal shift. Mediastinal shift. That means I just took a chest x-ray and where the heart is supposed to be is shoved over. So all that air accumulation, say I have a tension pneumo on my right side, all of that air accumulation in my tension pneumothorax between my lung and my pleural space and my thoracic cavity is building up so much pressure that it's not only causing my trachea to shift to the left, it's also causing my heart to shift to the left. That is called a mediastinal shift.
And this is only with tension pneumothorax.
Those are only with a tension pneumothorax. Those are both cardinal signs, hallmark signs of a tension pneumothorax. With the trachea deviation, you can see that just by looking at someone. You don't need a mediastinal shift. But with a mediastinal shift, the only way you can see that is with a chest x-ray, okay? There's also something we call a spontaneous pneumothorax. This is caused by something called a bleb, B-L-E-B, bleb. You can have one right now. I could have one. Christopher could have one. God forbid Henry could have one. Okay. It is a weakening within the lung tissue. It's like a little bubble. And it can spontaneously pop. It's very unfortunate and sucks. And you don't really know if you have one unless you like went in with like bronchoscopy or something to like see the actual lung tissue. It's a weakening in the wall of the lung tissue. And it's like a bubbling where if there's too much pressure, it can spontaneously pop. Okay. So when you have the rupture of a bleb that's the primary, there's no history of lung disease. There's absolutely no reason why you should have this bleb and why it has ruptured. It just happens. Please don't happen to me, okay? Secondary, it happens because there is tissue trauma or lung disease inside the lungs, okay? So primary, there's no reason. It is completely spontaneous. Secondary, there's a history of lung tissue. There's a history of lung disease. Something's going on with the tissue and is causing that bleb to rupture. So a closed pneumothorax can happen from two different things. A spontaneous pneumo from a ruptured bleb or a rib fracture. It could probably happen from trauma too. If you were to hit your chest wall hard enough where it ruptured a bleb.
Similar to an aneurysm?
Kind of like an aneurysm, yeah, where there's a weakened space, because an aneurysm is a weakened wall of an artery, right? And it ruptures. So yeah, it's kind of the same idea. So then we lead into tension. A tension pneumothorax is a medical emergency. So air cannot escape, causing increased pressure within the thoracic cavity. When you have this, your patient is going to have severe dyspnea, severe shortness of breath, and painful inhalation and exhalation. You will see an increased heart rate, an increased respiratory rate, because they're not getting enough oxygen in. Your heart and your lungs are going to try, your brain are trying to compensate from not being able to breathe adequately.
May I ask a fast question? I'm sorry. Would you
Yeah.
see was it asymmetrical chest rise and fall, or like one side's going and the other
Yeah.
isn't? Okay.
Yes, you will see asymmetrical chest rise because there's no ventilation happening on that side of the pneumo. Nothing at all. You also will have absent, key word, very important word, absent breath sounds. Nothing. No breath sounds. Tracheal deviation and a mediastinal shift. Anybody watch the first episode of The Good Doctor way long ago when it first came out? And he saved was it a guy or was it a kid?
It was a kid.
It was a kid. The kid had a tension pneumothorax, and he knew it because when he looked at the patient and assessed the patient, he saw a tracheal deviation. The trachea was no longer midline, it was shifted. And he provided a needle decompression and let the air escape from and relieve the tension. It's like a pressure cooker. Okay. So the treatment must be a needle decompression, which can look like in a very extremely emergent situation, can look like The Good Doctor. Okay. That is not common practice. That is a very truly emergent situation that you have to save someone's life. On the other side, that's when we put in a chest tube. Okay. In a controlled ER, or can even happen bedside, you pop in a chest tube to relieve that pressure. Okay. So these symptoms are extremely important. Dyspnea, absent lung sounds on the affected side, hyperresonance on percussion. When you percuss the lungs, it's full, right? There's something under it. It's like when you knock for a stud, okay? And you finally hit that stud and it's like a dull, like dum dum, right? But when you're not over a stud, it's a shallow. It sounds different. It feels different. There's air behind that wall. So that hyperresonance is there's nothing there underneath, under palpation. Okay, that's more of a physician thing, not a nurse thing, by the way. Subcutaneous emphysema, which is when that air gets trapped in the subcu tissues and it can't escape. So it's that crinkly. Unequal chest expansion, so asymmetrical chest rise and fall. Tachycardia and hypoxia. I need you to know the 3 different types of pneumothorax, what causes them, how we treat them, the symptoms of them, and prevention of a pneumo. How do we see a pneumothorax? How do we see a tension pneumothorax? How do we recognize it? How do we prevent it? How do we treat it? Okay. Any questions about the 3 different types of pneumothorax? Okay. Now we go to a hemothorax. It's the same idea, truly. It is the same idea, except instead of space or air taking up the space, it's blood. Okay. So blood leaks into the pleural space, and this is most likely caused by surgery within the thoracic space, trauma. It's missing trauma. like blunt trauma. Oh, it has it up there. Sorry. So your causes can be from a PE, thoracic surgery. Then we have penetrating and blunt force. So penetrating chest trauma is going to be from a puncture from the broken rib, which by the way, is on this side too. So it can cause both. It could cause air or it can cause bleeding because the lung tissue is vascular. What if it hits an artery? Okay. Gunshot wound, stab wound, blunt force trauma, car accident, a fall, anything where you're hitting something so hard and it's going to cause severe trauma to that chest wall and could cause bleeding within that chest cavity. Your symptoms are very, very similar. You have dyspnea, you have absent lung sounds on the affected side because there is no oxygenation occurring on that side. Okay. Dullness on percussion. There's a stud there. It's full. It's not air where we hear that, where there's no stud. We knocked and it is full behind there. It is a dull sensation. If you're at home, when you get home or when we stand up, go knock on the wall and feel the difference between the studded wall and when there's nothing behind it. If you've never done it, I feel like most people have done it.
I don't.
You've never done it?
No.
You ever
just see
hang
I
up-
want my picture and I just start hanging.
She said, I see where I want my picture and I hang it. Okay,
I've actually noticed a difference.
when you get a chance, go over to the wall and go knock on the wall and feel the difference and hear the difference.
Where it sounds a bit dull.
Yes. The EMS, but who was it? Medics, somebody told Adrian that a hemothorax feels like knocking on a watermelon and a pneumothorax feels like a basketball. So one is filled with air, one is filled obviously with watermelon. But it's full. The point is that it's full. Okay. Bloody frothy sputum, hypotension. What is the hypotension from? Blood loss. Yes. Unequal chest expansion and tachycardia and hypoxia. So really the big differences here is that with air, you have a huge risk for subQ emphysema. You also have hyperresonance on percussion. Bless you. With a hemothorax, you have dullness on percussion, so it sounds full, and you have hypotension occurring from blood loss, which could then lead to shock. Okay. So there's only slight differences.
The ED docs told me that was his constipation. They have done that a couple times. He had like.
Oh, percussion? Yeah.
So they kind of different sounds.
Percussion is something that doesn't come easily to a lot of people. It comes more from experience. That's why, like, when you see physicians, if you've ever had a physician on your own body, like, put their hands on your abdomen and kind of like knock. Like, as a nurse, like,
Yeah, I've done.
nobody's ever taught me that. Like, I don't know the difference in like what I'm feeling in the knocking and I mean, yes, do I palpate the abdomen and feel for any lumps, masses, whatever? Absolutely, especially in children, if they're constipated, you can actually feel the stool in their abdomen. But when physicians do that knocking and percussion, that's something that if you have the opportunity to learn it from someone that knows it and is experienced, hell yeah, you learn it. But it's not something that you really are doing as a nurse.
Yeah.
With percussion, unless you're really being taught by someone that has experience doing it.
Most of the nurses.
It's hard to teach. Percussion is hard to teach.
They're advancing their career. Like,
Yeah. So when we're talking about treatment for both, the procedure is going to include a chest tube insertion to drain the fluid or air and to re-expand the lung. We can do what's called a thoracentesis, which is where we go into that space and we remove the fluid. This can be done before chest tube placement, while you're placing the chest tube, okay? So this thoracentesis can be done by itself, or it can be done with chest tube placement, okay?
Not a provider doing that too.
Oh, that is not a nurse aid. We are assisting. You are assisting the physician placing a chest tube.
Oh, no, I mean the person.
Oh, thoracentesis is not done by a nurse. So speaking of pneumothorax and hemothorax, a chest tube must be placed after a thoracentesis. There are situations where a patient can have a thoracentesis and not have a chest tube. We're not talking about those. We're specifically talking about hemo and pneumothoraxes. Okay. So if you are doing a thoracentesis for this reason of a pneumo or hemothorax, you must place a chest tube afterwards. A thoracotomy as part of the chest wall is removed to reinflate the lung. This is very severe. This is like your trauma situations. This is your patient's going to SICU afterwards. This is not your regular run-of-the-mill pneumo. Okay. Chest tube placement, you should have their suction tubing ready and available. Provide pain management prior to the procedure if it's possible and ordered. In an emergent situation, it's hard to provide that when your patient's dying in front of you. It's hard to be like, oh, let me go get some morphine. Okay. So if it's planned, plan ahead and medicate your patient beforehand. Provide supplemental oxygen. Your patient's probably already on oxygen because they have a pneumo or a hemothorax, right? Chest x-ray to verify the placement. This is extremely important. The physician must verify placement. Okay. Monitor vital signs per policy after procedure. You need to make sure your patient is stable. And keep an occlusive dressing over the site and keep an occlusive dressing in the room with sterile gauze and a bottle of sterile water, just in case crap hits the fan and your chest tube gets removed. Nursing interventions, you want to monitor vital signs, the chest tube insertion site. I mean, obviously, we want to assess that site. We want to make sure it's not red and leaking and purulent and nasty looking, and it's still at the insertion point that it's supposed to be at. So they actually, when they're suturing the chest tube to the skin, this isn't just put in and then just like, oh, we're walking away. The chest tube is sutured to the patient's skin, okay? Because dislodgement of the chest tube can cause a lot of issues. So when we're looking at the site, we want to make sure that the tube didn't get shoved in more or pulled out a little bit, because then we need to call the physician and check placement. Okay. Lung sounds. If all of a sudden your patient has gone from decreased lung sounds to now they're absent, something's wrong with your chest tube and you now have a pneumothorax. Okay. Monitor the chest tube for air leaks within the water sealed chamber, the color and amount of the output, the water level or suction to ensure the suction level is adequate. The normal amount of suction for a chest tube is -20. That is the normal amount of suction for a chest tube.
For both.
For both. Do you ever, in a million, quadrillion, lifetime years, ever hook your patient's chest tube up to the wall suction?
No.
No. No, 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 no. Never in a million years. I'm talking about the tube that's coming out of their body. Because I want you to remember, this tube right here on my picture, this connects to my patient. There is this right here on top of the chest tube drainage system is a little port that you connect the suction to the wall. So there's suction coming to the wall that goes to the drainage system. And then the drainage system has a tube that then connects to the patient. You never connect the tube that's in the patient to the wall suction. Ever. In a million years.
This
Negative.
might only apply in some fields as well, but you should also never connect your chest tube to surgical suction, which I had read somebody connected their patient's chest tube to a Neptune, and I was like, did they deflate like a space saver?
So she's talking a Neptune, and I didn't know what this was until I started working in the OR. You're never going to see one unless you go into an OR. A Neptune is about yay high, and it is a huge suction machine that is made for the OR. It has a very large canister on the top that holds, I think, like
4 liters and then 20 on the bottom.
yes, thank you. I was going to say 5. 4 liters on top, and then it has a separate chamber on the bottom that holds up to 20. So it has, on the front, it has 4 ports that you can actually attach 4 different suction tubings to. And if you ever are in a situation where you're in the OR, you never in a million years ever put a chest tube to that suction because it's very intense suction. I mean, you can put it up or low, but it literally tells you when you turn on the Neptune, do not hook up your chest tube to this machine. Like it literally tells you that, it warns you on the screen. Okay. Encourage the patient to cough and deep breathe. Teach them to splint the area while coughing, just like if they had a rib fracture. Reposition to promote drainage and encourage ambulation per the physician order. If your patient is on bed rest, please follow your physician orders. If they do not have bed rest orders, you really should get them up and moving and walking. At least do some range of motion. Questions on this slide? Okay, so that completely wraps up chest tubes for us. Notebook LM made some pretty cool chest tube stuff. That link was sent in the group email. Have you seen it?
So I was looking for it.
Okay, maybe I need to read.
Mine's weird. I'm on my phone, not the computer.
Could you repost it? Because I didn't see anything either.
I don't know. I'm gonna send it right now.
Last thing you sent was the EOG.
No, it was days ago. It was a while
Yeah,
ago.
I
Sent it out. So this is the one respiratory thing that they sent or they made. Let's see. Oh, I guess they didn't really give me a lot on chest tubes. Yeah, they only really gave me one slide and I don't like how it looks.
Here's a stupid question, but does anybody know how to actually print them off a notebook like that? Because I don't know, for some reason, I don't know how to do it.
All you have to do is download it. It has an option to download it. Okay, so we are now moving on from chest tubes, hemo, and pneumothoraxes, and everything that comes with it. Everybody okay with that? Okay. It's 11:26. Do we want to go to lunch? Are we here? Is it a 2:30 or a 3:30? 3:30. All right, let's go eat, and I will see you back here at 12. All right. Are we ready? Everyone feel their little bellies? Okay. Rashonda, I approved that for UH. I think you also need to do it for Ross. Like you did it for the UH rotation in ASMAP. But there's also your Ross thing where you have an X. So both of them need to have that green check. Yeah. But it's good. It's adequate. Like it's good. Oh yeah. Yeah. Okay. What? No. I ain't gonna lie.
Period.
Yeah. And I don't have the I don't have the nurse manager's email. It's fine. It's gonna be great. All right, so we have two different types of artificial airways. So your first type is an endotracheal tube. You'll hear me refer to it most of the time as an ET tube. And then we have a tracheostomy tube, which I shortened down to trach. So general recommendations are that a trach should be placed if your patient is requiring more than 21 days of intubation. We talked about PEEP a little bit, and we're going to talk more about PEEP in the next 3 hours. But the higher your patient's PEEP, the less likely they are to be able to get a trach. Okay. So you have to have a normal PEEP, positive and expiratory pressure, to be able to have a trach and have adequate ventilation. ET tubes should, in the perfect world, should be less than 10 days. Can go up to 21 days. In severe situations like during COVID, because our patients had such high PEEPs, we couldn't trach them. So we had no choice but to keep them intubated for longer than that 21 days. So there are situations, pre-COVID, it was a never. It was like, you're never keeping anybody intubated more than 21 days. Like, that's just ridiculous. And then COVID obviously changed everything for everyone. So these artificial airways are to provide adequate ventilation. Mechanical ventilation may be required to ensure adequate oxygenation. So we need some way to get air in and air out. Why should we not have someone intubated for more than 21 days?
High risk for infection.
Solid. She said high risk of infection.
Can it depress their ability to self-ventilate?
So you could have some depression of the respiratory drive. You could. It's definitely not like a top reason. It could qualify as a reason, but it's not a top reason. Because during that time, you're going to be trying to get that patient back to breathing on their own in some way, shape, or form with different ventilation settings. So the main reason is that if you've ever seen an endotracheal tube, and we're going to look at it, I think, on the next slide, maybe. Yeah. So you see that where it says inflated cuff. So endotracheal tubes have a balloon.
You think that's smaller?
Oh, yeah. So ET tubes have a cuff at the end of the tube. And this cuff is extremely important because it not only keeps the tube in its place. Sorry, excuse me, I have hiccups. It stops air from coming out, right? Because we want air to come in and we want air to come out, but we want to control it. I only want it coming out of the tube. I don't want it coming out around the tube. Okay. Also, it has some protection against aspiration. Okay. So if something comes down here and gets trapped above this balloon, it's going to prevent that tube feed or something or whatever secretions from getting past and down into the lungs. Okay. This tube is inflated with, it can hold up to 10 cc's of air, depending on the size of the endotracheal tube. Okay, there's a lot of different sizes. We're talking babies all the way to full grown, 350-pound linebackers, right? Like we have to have different size tubes for each size human. All right. So that means that our cuff size is going to be different for each size human. They take a maximum amount of air different than other tubes. So what happens is this tube is up against the trachea. And what happens when we put pressure on something?
Oh, injury.
We get a pressure injury. And what can happen if you keep someone intubated for an extended period of time is that you can actually get a tracheal esophageal fistula, where you have a hole that occurs from pressure and tissue death between the trachea and the esophagus.
What's it called again?
Tracheal esophageal fistula. A fistula is a hole that's not supposed to be there. Okay.
You can't just move it up and down?
No.
Like deflate it and replace it?
No. Yes and no. No. Because you want your endotracheal tube to be in a very specific place. It can't go all the way down to the carina. It can't go into the right or left main stem bronchi. And we're also talking about a situation where your patient is extremely compromised. So moving that tube, deflating, reflating, moving it, re-intubating, extubating, re-intubating, this is all causing a lot of trauma also in different ways. And if your patient's intubated for this long, there's a reason. They're not ventilating, they're not breathing great. So touching that tube, I don't want to touch that tube. I don't want to touch it. My patient's already compromised. They're already in a severe ventilation situation. So me messing with it is not going to help them in any way, shape, or form. Okay.
I saw an RT go in one room and she was on a breather valve for like 4 or 5 hours and they just disconnected for a second. 5 minutes resident on.
So it depends on your patient. Okay. So when a patient becomes intubated, this is the act of inserting an ET tube into someone's airway. We call that intubation. When we remove it, we call that extubation. So this is an airway for emergency airway management. This is performed by a physician, an anesthesiologist, a CRNA, and an advanced nurse practitioner that specializes in acute care, like Shauna. My Niles students and my North Canton students know Shauna. So she is the nighttime acute care nurse practitioner in the UH ICU, and she also teaches clinical for the Niles students at St. Joe's. So she, with her acute care degree, advanced degree, she has been trained to intubate also. We also have something called nasal intubation. And this is very specific to when there is facial or jaw trauma. I'm going to talk about some pretty heavy things. And sometimes when I talk about heavy things, I don't want you to ever feel like I don't have compassion for these things, because you know how passionate I can be. And sometimes we use a little bit of humor to help get through those traumatic things. And I don't want to trigger anybody, but we are going to talk about some heavy stuff. So if you are in a situation where you're working in the ED and you have a patient that has just tried to commit suicide with a shotgun and has blown their whole bottom jaw off and is still alive, do you think that you are capable of intubating that person?
No.
No.
Not the regular way anyway.
That person is not going to be able to be intubated in this way. Okay. So when we're talking about those trauma situations where these things can occur, obviously that's not the only way or reason that could occur, but that is probably one of the most common ways that occurs, unfortunately. It can be very difficult. So the nose connects, the nasopharynx connects down into the larynx and then down into the trachea. So you can use a smaller ET tube to do a nasal intubation that will go through the nose, down the nasopharynx, past the larynx, and into the trachea. Okay.
Oh, there was a viral video where they did a transorbital intubation through the eye.
Really?
Yeah. Yeah. So cool.
That's scary though. Like,
Yeah.
why?
I
Like, what
don't-
happened?
I don't know.
She
It was
said
just-
there
it was just
was
a
a
picture
viral
of-
video of
Yeah.
someone that had a transorbital intubation.
Like the eye was.
Like they would have had to go through the sinuses or something. Like that just sounds really scary. So
If you get a chance.
I'm gonna have to look that up at some
It
time. So the best way, and I want you to put a star next to this, the best way to confirm your endotracheal tube placement is by an end-tidal CO2 detector, which is called capnography.
That's the best way. So the chest x-ray means nothing.
Oh, no. This is gold standard. This is gold standard. This is, so when you intubate someone, we have these little filters. They're blue. I think they start out blue. And when you intubate and when you're in the correct place and carbon dioxide gets exhaled through the tube when you're in the lungs, it turns yellow. So we have that one thing that helps us, that can say, okay, we're in the right place. Now, we also have, which is part of every defibrillator and also part of ventilators, is that there is a little tube that connects and senses the CO2 and will give you a number for an end tidal. So there's two ways of assessing capnography, is with your filter that you can use on intubation. It doesn't stay. You use it on intubation just to confirm placement, especially in an emergency situation. Or we also have the little tubing that connects to the vent or defibrillator that gives us an end tidal CO2.
I remember this. We did this on a skill.
Donna?
Yeah,
But-
Miss Donna took- she
Donna
taught us
Gasper.
Yeah, those two things.
So another way to confirm your ET tube is with a chest x-ray. Your chest x-ray shows you the depth
How far
of
down it is.
your ET tube. Okay, so if you think that your ET tube is either going right or left main stem, it's too deep, it's not deep enough, okay? You should always get a chest x-ray to confirm the depth of your tube. Okay. If you ever question if your tube has been pulled out or inserted more than it should be, you should get a stat chest x-ray. No physician or advanced practice nurse in a million years is ever going to look at you when you say, hey, I think my tube moved a little bit. I want to get a stat chest x-ray to check. Never in a million years are they going to be like, no, how dare you even say such things? They're going to say, yes, please confirm placement. Please. Okay. So another thing is that when you're getting a report, your nurse that you're getting a report from, or you as the nurse giving a report, you're going to tell your oncoming nurse where that tube is. So just like when we talk about NG tubes, when we say, oh, it's 60 centimeters at the right nair, okay? When we talk about our ET tubes, we say it's 22 at the lip, or it's 18 at the teeth, okay? Whether they measure it at the lip or the teeth, that's up to, really it's usually it's the lip. We don't really do teeth. Usually it's the lip. But that should always 100% be passed down in report and should be one of the very first things that you look at when you walk into that room is where your tube is, what number it's at the lip, and make sure that it is in the correct position.
My
Okay.
nurse measured hers at the gum.
That's interesting. So did the patient have teeth? So at the teeth.
Yeah, she's reported it from the night shift nurse to her, and then to me, they all said at the gum.
Yeah, that's okay. That's okay. And that might be facility based, that might be nurse based. But the way that it's charted and the way that it's put in the note by the physician that intubated, or the anesthesiologist, or the CRNA, or the advanced practice nurse, or sometimes even a paramedic, because Chelsea, which ones are the ones that can intubate? Medics. So, and not EMTs.
Medic and advanced EMT can both intubate.
Yeah, so medics and advanced EMTs can both intubate, and just like a regular EMT cannot, correct? Okay.
No, we can't.
So, those people all know exactly where they place their tube. Okay. Sarah and Chelsea, when you guys intubate in the field, do you have the end tidal filters that you use?
The company that I worked for did have them.
Okay. And was it blue or yellow?
I think we had both.
Okay. So anyways, I just wanted to see if I was right. I'm pretty sure it's blue and then it turns yellow when it hits the CO2. So anyways, you have to have a way, if you don't have a machine with you, right? They're intubating in the field. They're intubating in an emergent situation. They have to have a way to make sure that it's not in the esophagus. And guess what's not in the esophagus? CO2. Okay. Nursing responsibility, bag mask must be present at all times. Every single ICU room should have an ambu bag right at the head of the bed. Every single one. And every single ICU room, every single hospital room, in my opinion, should have suction at the bedside.
We have both.
You better have both. But I'm saying that especially the higher acuity the patient, meaning the worse they are, the more necessary these things are. When you're on a med surg floor, you're probably going to find the ambu bag on the crash cart. When you're on a step down unit, you're probably going to find it either at the bedside if your patient has a trach, vent, BiPAP, or Airvo, the heated high flow. You're going to see it at the bedside. ICU, it's going to be at the bedside. And if it isn't, you need to make sure that you get one. Okay. Monitor vitals during intubation. Intubation can be a very chaotic time. You just went and pulled meds. You're giving sedation. You're giving paralytics. You're giving and you're making sure that you have your lines running. Your saline is going. Maybe you need pressors. You're also getting Levofed mixed. You're hanging all these things, doing all these things, and your patient is hopefully not dying. I had one lady who was literally like trying to sit up in the bed while we're intubating her. It was ridiculous. And trying to push propofol as fast as we can to get her down so we can intubate her. Okay. So it can be a very chaotic time. If it's your first time seeing something like this in intubation, I want you, the first couple times you stand back, you watch, you observe. When you get the chance to get in there, it's a calm chaos. Okay. You can feel your heart racing inside, your adrenaline is pumping, but you're calm on the outside and you're doing your job and you're doing it well. So, there is this little guy right here. I don't know if you can see me where I'm pointing. See this right here where it says cuff inflating tube? That is called a pilot balloon. I will never forget in a million years when I first started working in the ICU, I had a patient, his name was David. Not a HIPAA violation, this was like 7 years ago. You're never gonna know who that is. And he was a young kid, he was MR, and he was intubated with pneumonia. And he was, because of his history with psychiatric medications, he was really hard to sedate. And he kept bucking on the vent, which he was like coughing and like sitting up and like getting so like animated and like it was just so crazy. And his uncle was like sitting bedside, and brand new ICU nurse, and I'm just like shoving propofol down his throat trying to sedate this dude. And he is just, there's nothing working. His sats are falling. I'm like, what is happening right now? Come to find out, he bit his pilot balloon. This tube right here where it says cuff inflating tube. It's a little plastic tube. He bit it.
Wow, when he had the tube in his mouth.
He bit the pilot balloon, which, by the way, this is connected to your cuff.
Yeah, so that was deflated.
That's what you put there.
His cuff was deflated.
But I'm still trying to figure out how he got it in there with, never mind.
Because it got in the way of his teeth. And when he bit down and he was coughing and he was bucking on the vent, he bit right through it.
It just seemed like the plastic from the tube is harder.
I'm not talking about the ET tube.
I know you're talking about that,
This little teeny tiny
but it's
tube.
in your mouth, so you're like,
It's not in your mouth.
what they got it to the
It's
side?
coming out of the mouth. This comes out of your mouth.
I know where it comes from.
Yeah.
I'm saying to get it in, you have the tube down your throat, so your mouth is like
So I think it got caught between his teeth.
the tube.
It was the
like,
perfect storm.
The pressure from the teeth.
It was, I'm telling you, it was the perfect storm. And I had nightmares about this dude. Now, listen here. You think that's bad? I say, I need help in here. And guess what? Nobody's coming. Ain't nobody coming. My ass goes out in the hallway and I said, I need help in here.
Oh, yeah, I'm screaming.
My charge nurse runs down the hallway and she's like, what's wrong? At the same time, don't you know, a code was called on the other floor.
Yep.
A code was called on the other floor. My intensivist was at the code with all my residents. I call in respiratory. Respiratory's coming in. You can't fix this. The tube has to be replaced.
Yeah.
I can't put on a new pilot balloon. I have to replace the entire tube.
Elbow.
Ain't nobody there to intubate. There's nobody there to intubate. No, I have my senior, I am a baby ICU nurse. I have no idea what's happening. I am standing there and I'm like, oh my God, what's gonna happen? I don't know what's happening. Thank God I have my senior ICU nurses that know everything and are in there trying to calm me down and take care of my patient. I got respiratory therapy at the head of the bed. They're bagging him. I'm losing my shit. I'm like, I don't know what's gonna happen here. Finally, thank God, our respiratory therapists are trained in intubation. And my respiratory therapist had to re-intubate my patient while my intensivist and all my residents were at another code in the hospital.
Oh my God.
Worst night. I'm telling you, I had nightmares for weeks. I'll never forget David, ever in a million years.
That's crazy.
So, do me a favor, tape your freaking pilot balloon somewhere else, not on your tube, so it can be bitten by another human.
Right.
Okay? I bet you won't forget that.
No.
You have to make sure you go through the vocal cords before you inflate the balloon, because the vocal cords open and close, and they open and close. Well, it has to go past, because if your vocal cords are closed, then you're not going to breathe. Okay? Because your vocal cords are in your trachea. What can happen to your vocal cords if they're kept open by a tube?
They can get damaged. They can obstruct your airway and swell. We just learned.
They can become damaged and paralyzed.
You said that.
Your vocal cords are pushed against the trachea, and pressure is happening against your vocal cords and keeping them open. And it can cause damage to your vocal cords. And eventually, if intubated long enough, can cause paralysis of the vocal cords. It's super sad. And you never know if it's going to happen.
Right.
It just happens. There's no set amount of time that if you extubate within this amount of time, it won't happen, right? You could be intubated for a day and it could happen. You could be intubated for 3 weeks and it could happen. It's just an unfortunate complication that can happen.
Okay.
That's what we were talking about with our patient, because her voice was so
Raspy.
So,
no, it was so.
do you have to paralyze when you intubate?
Yeah.
You do not have to paralyze when you intubate. You'll see a lot in the OR, depending on what procedure is being done. There are some OR procedures that you cannot use paralytics because they have to be able to assess the nerves and muscles.
Can you sedate? Well, if sedate, that's the same.
So, with saying that, when you have to give a paralytic, do you give your sedative first or your paralytic first? You absolutely give your sedative first. Could you imagine if you were the person getting intubated and they paralyzed you first?
And you just know.
And you're just laying there all aware, but you can't breathe and you can't move?
Oh, yeah, freaking out.
And then all of a sudden they shove a tube down your throat because they didn't give your sedative yet? Please make sure you sedate your patients before you paralyze them. Now, NCLEX, a registered nurse should not be pushing propofol. Okay? We can give it as a titrated drug. We can give paralytics as a titrated drug. But registered nurses should not really be pushing propofol. World. In real life, when you're in a code and something's happening and your patient is being intubated at the bedside, your physician is at the head of the bed intubating. I'm drawing up my drugs and I'm pushing my drugs. Okay. It's the trust, the teamwork, and knowing and trusting that that person that is pushing those drugs is educated to do so. Okay. I'm not giving him to some willy-nilly new grad that's never touched propofol in their life and be like, shove it. No. Okay. You're going to be taught these things. It's not going to be your first day and your first code and they're just like, here you go.
Please.
Have fun.
I would just walk out the room.
Tisa, I'm out. I'm leaving.
All right, let's try this again.
Okay.
Oh, wrong.
So, does it happen? Yes. Are you supposed to do this? Not really. Okay. These drugs are meant to be titrated, and are only bolused in specific situations. Okay. Any questions? We didn't really talk about trachs. Let's talk about trachs a little bit. Which, I mean, it doesn't even show a picture of it, but let's talk about trachs anyways. So, a tracheostomy happens in your throat, in your neck, right? We've all seen a trach, right? Has anybody never seen a trach in their life? Anybody, anywhere? If you haven't, please Google. Okay. A tracheostomy is a short, curved tube, probably about 4 inches, I would say. They can come longer, which are like XLs, and are for some people, but most standard trachs are about 4 inches long, I would say. They can come with a cuff or without a cuff. New trachs should always have a cuff. Okay. Cuffless trachs are for patients that are chronic, that have a chronic tracheostomy. These are the patients that can talk with their trach. If you have an inflated cuff on your trach, your patient will not be able to speak because that is going to stop the use of those vocal cords. Okay. When it comes to tracheostomy care, you have what we call trach ties, and they attach on one side of the trach plate. They go around the back of the neck and attach to the other side. You never, ever, ever, ever untie both sides of your trach at the same time. Okay? When you are changing those trach ties, you should always, always, always have one side tied at all times. Okay? What happens if you are doing trach care and the trach comes out?
Put it back in.
You put it back in. Right back in. Okay. You should always have, especially with a new trach, you should have some hemostats on the board, because with a new trach, just like any new opening, when you take it out, it goes whoop, it closes. Right? And we don't want it to close. That's our airway. Okay? So if something happens and you cannot get that trach back in, you have a pair of hemostats and you put them in that hole and you open that hole. And you are calling there's no time for art. You hit that code button and you are going to get a team in the next 30 seconds to a minute. I don't care if that patient is still alive, you hit that code button because that's the fastest way you get somebody to get to your airway. Usually trachs have an inner cannula. There's 2 different kinds. There is the kind where you don't have an inner cannula, it just stays in. Most of them have an inner cannula where you like turn it and unscrew it. You take that inner cannula out. This inner cannula is either permanent or disposable. A lot of them nowadays are disposable. But before, most of the time, before we had disposable, they were permanent, right? We had our trach trays, our trach cleaning trays. It came with pipettes or pipe cleaners, and you had a mixture of sterile water and peroxide. It was a 50-50 mixture. And it was not really sterile, kind of sterile. You wanted to be as clean as aseptic. You get your inner cannula, you put it in the mixture of water and hydrogen peroxide, you get your pipe cleaner, you clean it all up, you dry it off, you pop it right back in, okay? And that's a once per shift thing. Nowadays, they're disposable. You take the inner cannula out, you throw it away, you get a new one, you pop it back in. You should always, always have a couple, at least one, new inner cannula, okay? And you should always have a spare, same size trach that they have in their body bedside. Because if something happens and that trach comes out and for some reason you can't reinsert, you should have a brand new one at the bedside to reinsert if an emergency were to occur. Okay, these are standard trach protocols. All right. If you've seen ever in your life a patient with a trach that can speak, they have what's called a Passimir valve. It is a little cap that goes on top of the opening of the trach, and it allows them to be able to capture air to be able to speak, which, by the way, we need airflow to be able to speak, to be able to use our vocal cords and form words.
The worse someone's respiratory issues are, it'll be harder for them to speak.
Yes. So she said the worse someone's respiratory issues, the harder it is to speak. Yes. And specifically with a trach. So like I said, if you have a cuffed trach, you will not be able to speak. It takes practice. So she's saying that her cousin had a trach and he was able to say like one word sentences, not really more than, not really a phrase, but he could say words. And that takes a lot of practice. So I'm assuming it was a chronic trach. Yeah, that takes a lot of practice and you literally have to train yourself to speak in a different way, truly. And those Passimir valves, they will kind of, they kind of look like a strainer too. Like it has little holes. So they have to be able to have a really good ventilation on their own to be able to use a Passimir valve. A lot of times when you're trach training and a patient is in a long-term care facility, like an LTAC, long-term acute care facility, post-trach, you'll have speech therapy go in and they'll try on the Passimir valve and the patient might not be able to tolerate it. They might desat, they might have a hard time because they're not getting enough air. So it's for sure, and then talk about it. Any questions on trachs? Yeah.
The disposable inner cannula, how often is that being changed?
The disposable inner cannula should be changed per shift. Yeah. And those usually come from Central Supply. So it is your job as the bedside nurse to call Central Supply and say, hey, this is what I need, and then bring it up. It's not going to be stocked on the floor a lot of the times. Anybody, Lisa, I know you've done a lot of trach long-term for a little bit.
Unfortunately.
Yeah. Anybody else that's done a lot of long-term trach stuff? Am I forgetting anything that you think I should have added?
No.
Okay. So any trachs before we go on to ventilation?
No.
Oh, I do.
Yeah.
Sorry, Heather.
No, you're fine.
So I am assuming that, I hope it's not dumb. I'm assuming the measurement for depth is gonna vary on the individual.
Yes.
You know, when we check placement, it's gonna vary on each individual.
Yes. She said, I'm assuming that the measurement for ET tubes
Yes.
we're talking about varies on each human, 100%.
Okay, so it's not like-
100%. There's a formula that I don't remember because it's really for people that place endotracheal tubes. They are required to know that formula, but there is a formula to figure out ET tube length, and it's like age times something divided by something, and I don't remember what it is,
So like,
but there is a formula for it,
when we have.
and you're not required to know it,
when we have-
especially if I don't know it.
when we have-
Yes.
Like, is there like
Yeah, so, well, we're talking about selection before intubation.
Oh.
Yeah, so Jackie was saying that, you know, when you're measuring for an NG tube, it's the the nose to the sternal notch. When it comes to ET tubes, it's not really, honestly, when a advanced provider has intubated as many people as they do, they just look at you and they know what size. Weight impacts it a lot. It's harder to intubate heavy people, 100%. It's 100% harder to intubate heavier people because of the soft tissue around the neck. The more soft tissue you have in the neck, the harder it is to intubate. Yeah, and the more neck extension they'll need to be able to clearly see the vocal
Well,
cords.
at least I got a long day. I got a lot of.
You have a beautiful neck. Okay. Are we ready to go on to mechanical ventilation? Okay, so a ventilator is a machine that takes over the function of breathing for patients that cannot maintain adequate oxygenation on their own. It uses positive pressure to force air into the lungs, okay? Normal breathing uses negative pressure. Our lungs work by negative pressure. So when we inhale, when we have that sense of inhalation, we're inhaling into a negative place. It's kind of like a vacuum. So we're just taking it all in, right? We can choose whether we want it to be a larger breath or a smaller breath. While we're talking, it's sometimes a smaller breath. When we're, when you're about to jump in water and you want to hold your breath, you can inhale big, huge tidal volume, right? But when the act of inhalation and exhalation works in normally under a negative pressure. So mechanical ventilation, the fact that it uses positive pressure is actually quite foreign to the human body and why it can cause trauma and why we need PEEP to keep everything open during exhalation. So we have a couple different ventilator modes that are the most common. You have assist control. This is used for patients that require full ventilatory support. So remember we talked about on Monday, we talked about a tidal volume. The tidal volume is the amount of air that you breathe in at one time. And remember I said, if you're talking, it could be like 250, 300, right? If you're just sitting there, a normal tidal volume for a full-sized adult would be like a solid 500, okay? But if I'm really trying to take a really big, deep breath, it could be like 900 or 1,000, okay? It depends on the compliance of the lungs at how much tidal volume that you can get, all right? So when you're looking at a ventilator, you have a couple settings that you need to look at. Number one, you have the rate of breaths that are delivered every minute. So a normal respiratory rate is what?
12 to 20.
12 to 20. So you would assume, not that I usually say don't assume, but we can assume that a ventilator should probably be set between 12 and 20, okay? We next have the tidal volume. If your patient is receiving a set tidal volume, then that has to be set on the ventilator. So say it's set to 500, okay? The next setting is your FiO2, the amount of oxygen your patient is receiving on every breath. So remember, room air has 21% oxygen. We can go all the way up to an FiO2 of 100% on a ventilator. Okay. Our next setting is going to be our PEEP. Our standard PEEP is 5. We really don't want to go over that 14 mark. I was talking to the respiratory therapist yesterday. It was really nice and enlightening. And she did say that you could go, I think she said 25, like the highest
She
PEEP.
said she doesn't even like to go over 12.
She doesn't like to go over 12, but the highest PEEP that you really could ever go to is 25. I've never seen it I don't even want to know the patient situation that you would have to be in to have a PEEP of 25. That makes me very uncomfortable. The higher the PEEP, the higher the pressure is in the lung and the higher chance you have of a spontaneous pneumothorax, literally popping the balloon. We don't want to pop the balloon. That's really bad.
Clearly, that's not the ones. We
No.
need them.
So, assist control, preset tidal volume, and it delivers a mandatory number of breaths. So a preset tidal volume and a preset rate. If your ventilator is set to 12, your patient will breathe 12 breaths per minute and no less, because the ventilator will make sure that they get a 500 tidal volume 12 times during that minute. Okay. Breaths, the breaths that the patient triggers will also develop or deliver a set volume. So if my patient is intubated on AC with a set rate of 12, that does not mean that my patient cannot take spontaneous breaths. If my patient takes spontaneous breaths outside of the 12 that are already set, the ventilator says, I see you. I see you're taking a breath. I'm going to make sure you get that 500 tidal volume on your spontaneous breaths. Okay. And that's called breathing over the vent. So I'm ventilated. I have a set rate of 12. But you see on my vent that I'm taking 16 breaths per minute. That means that those other 4 breaths are my own spontaneous breaths, and the ventilator is making sure that I'm getting the set tidal volume that I had for the other 12. That is assist control. This can be completely and totally without spontaneous breaths, because no matter what, I'm getting those 12 breaths. So I don't have to breathe at all on my own. I'm going to get them anyways. Okay. So this is the most supportive when we're talking about assist control. Okay. This can lead to respiratory alkalosis if the patient is tachypnic and breathing way over the vent. So say I have a set rate of 12 and I'm on AC, but I'm taking an extra 14 breaths. So I'm breathing at a rate of 26 respirations per minute and I'm tachypnic. I could absolutely send myself into alkalosis. What do you think your patient needs? Relax. We need to slow breathing. Am I going to go to my patient's bedside and say, hey, Mr. Jones, I really need you to relax. I'm going to increase my propofol. Okay. And when we're talking about sedation, we talk a lot about propofol because that's kind of like our gold standard. That's our main guy, right? But we also use fentanyl as sedation. So you could see your patient on a fentanyl drip, propofol drip. You can also see them on a Versed drip, midazolam. You can also, in specific cases, see them on a ketamine drip. That's not common. And then in not ventilated patients, I'm not even gonna say that.
Without ventilated, I want them to get me.
That Michael juice.
I had a question then. Whatever.
So we'll get there, but yes, when a patient is on a spontaneous breathing trial, first of all, your sedation has to be off. You cannot expect a patient to perform a spontaneous breathing trial with them being sedated. Sedation has to be removed. Time out. We're getting ahead of ourselves.
Well, I'm asking because I didn't know my patient had to do the breathing challenge. She had literally kept telling him, well, you need to relax. And I was under the impression he was on AC mode. But that's why I'm asking, AC mode is off on a breathing trial.
You do not use AC mode for a spontaneous breathing trial.
Okay.
No, what were you gonna say? Is it jumping ahead?
Yeah.
Then don't say it. Wait until I get there.
Okay. It's
'Cause I'm
about
probably gonna get there.
sedation, So probably.
Okay.
Maybe, I don't know. Question.
What?
So if your patient is sick as neck and how would you handle increased sedation? Do you call the provider and like, hey,
No.
what's going on?
That's a good question.
Or is there like?
Was that your question? Okay, that's a good question. She said, if your patient is anxious, they're breathing over the vent, they're tachypnic, hyperventilating, however you want to call it, what do? I mean, I already just told you that you shouldn't be bolusing propofol,
Right.
right? So we have what's called titration parameters in the ICU. All of our rescue meds, our sedation meds, not all of our rescue meds, that was the wrong thing to say. All of our sedation meds, all of our pressors, they all have titration parameters. So I can start you at the very lowest amount of propofol and I can max you out. That is on my call and my license. It is up to my nursing critical judgment and care to determine the safe level that you need as my patient to be able to be comfortable and breathe and do it and be comfortable on the vent. That is my job.
I know so there's like a,
So that's very different. She said if it's like, so when you're talking about titrating heparin, you're titrating heparin because of the labs. And you're doing it as a very strict protocol.
That's what I mean, if you have it's within the medication order, like is it there?
No,
No,
It's
that's-
just.
no, it is, there are no titration directions when it comes to sedation.
Okay.
It is your nursing judgment. That's on you and your license. So that's why it's so important for you to be trained appropriately to care for these patients.
Now, I guess
he said like propofol could go to 50.
Yes, it can go to 50.
if you get maxed out, that's when you're gonna call the physician because you've done all that you can do.
If your patient is maxed out, so for example, patients that have a history of IV drug abuse, have a history of a lot of psychiatric medications, have a history of alcohol abuse, are a lot harder to sedate because they have a higher drug tolerance.
For David.
Poor David. Fault, he's
My
on
guy
Mar,
on Monday.
right? So these are the patients that you're probably going to need more than one sedative,
Okay.
where you're going to hit them with propofol and fentanyl and Versed. And then if you even get even farther than that, then that's when we're talking about adding ketamine.
You can definitely tell, like, when I was working for the oral surgeon's office, like, you can tell, like, who smokes weed and who does drugs and stuff like that.
Yeah, they're harder to sedate.
Yeah.
Also, redheads. Like, if you've ever heard this and you just thought like it was hearsay and people just like talking crap, like, no, it's real.
Oh, yeah.
People that have the red-haired gene are it has been medically proven that they are harder to sedate. It's something in their chromosomal DNA. I don't know the exact terminology, but it is 100% real. Redheads, true redheads. Even if you have the characteristics, like I have redheaded people in my family. My brother has red in his beard. When Henry was in his first year, everybody, is he at least a little gingery? No, he's not. Just kidding. I love redhead people, but statistically proven medically, red-haired people need a higher amount of drugs, specifically in this situation of sedation and during surgery. So it is 100% a fact. Any questions about AC? Okay. Then we're going to move on to SIMV. This is synchronized intermittent mandatory ventilation. This is used for patients that require partial ventilator support. It delivers a preset volume and number of mandatory breaths, but it allows the patient to take a spontaneous breath in between. So I said that over here for AC, I said that they could breathe over the vent, right? But when I said that the ventilator is going to say, hey, I see you, and I'm going to deliver the set volume to you. SIMV is that when you take a spontaneous breath, you take in your own tidal volume, whatever you want it to be, whatever that breath is going to be. There is no forcing of a tidal volume. It's whatever you're going to breathe. So you get the preset tidal volume with the rate that is set. So the 12 breaths that I'm set at, I'm getting a tidal volume of 500. But the extra 4 breaths that I took,
I get whatever.
one could be 200, one could be 500, one could be 700, one could be 50.
Was he gonna keep track of that?
That's a good question.
Cause like, when you wanna know like how,
So if
Long
you're
term
standing at the bedside and you're watching your patient take a spontaneous breath, it will tell you, yes, the machine has a history. Does it have like a printout? No, they don't have like a printout that you could like print out a paper, but you can go back in the history on the computer screen of the vent to see what those spontaneous breaths were. And if you're standing at the bedside and you're literally watching them take a spontaneous breath, you will see in real time the size of that tidal volume. Which is why this is our first step to weaning. So yes, when our patient takes a spontaneous breath over that set amount and they're taking their own volume, this is when we can say, okay, are you starting to be ready to start weaning? Are you taking an adequate amount of volume to try to decrease your dependence on the vent so that we can try to get you off of it? Okay. When we talk about CPAP, this is continuous positive airway pressure. This is used for patients that require the most minimum ventilator support. So there's no set rate. The only thing that they're getting is positive pressure when they're taking their own breath. So this patient is getting their very own tidal volume, their very own set amount of breaths. This is really the least supportive, okay? So when a patient is on a spontaneous breathing trial, this is when, like I said, no sedation. There is no sedation. The sedation has to be weaned down and taken off. And then you do a spontaneous breathing trial, you want to try to do it for at least 1 hour. If you see your patient immediately struggling, you are going to immediately go back onto an AC supportive control, okay? The goal is for that patient to make it that 1 hour. And then if they're not really exhausted after that hour and they think that they can keep going, then you may push it another hour. You may push it another hour because the more that they can spontaneously breathe on the ventilator, the more, the better they're going to do extubated. Okay. We did learn something from the respiratory therapist yesterday, and that was when your patient is doing a spontaneous breathing trial, if they become apneic for a period of time, so say, I don't know the period, I don't know if it's 10 seconds, I don't know if it's 15 seconds, I don't know the amount of time, I would have to ask. But if they were apneic for that period of time, the vent it senses every breath, right? So if they were to go apneic for that period of time, the ventilator is then going to kick on and take that breath for them. Because if not, and you're not there at the bedside to switch the mode, they could go into respiratory distress, failure, and then die, right? So if they were to be apneic for a period of time, the ventilator is going to say, hey, you're not breathing, I'm going to breathe for you. And then it's going to send off a big loud alarm and tell you it's flashing, I need somebody in here. And until someone physically goes to that vent and changes the vent settings, it will stay on that emergency vent setting to make sure that they're oxygenating until someone physically goes in there and switches it.
Look what I did. She was wrong.
So it's a safety net. It's a safety net. We talked about with the respiratory therapist yesterday, something that I never knew. She taught me something new yesterday. I learn something new every day. I really do, I swear. Your goal really should always to be to learn something new every day. But we were talking about the Airvo. The Airvo is a heated high flow oxygen delivery system. And it has like these little pillows that go on the nose. It looks like a nasal cannula on steroids. It has this big blue tubing, and then that big blue tubing goes to a little machine. And when you look at the settings for Airvo, it's going to say 50 liters per minute with an FiO2 of 80%, 60 liters per minute with an FiO2 of 70%. So what she taught me is that at every given moment, right now, you have a PEEP of 5. Right now, you're breathing in your body, you have a natural PEEP of 5. And that's what keeps your alveoli open. That's what keeps your lungs from collapsing. But what she taught me is that every 10 liters that you add to that Airvo equals 1 in PEEP. So whose patient was it?
Mine.
Today's patient was on, what was the liter? 60?
60.
No, it was more than that. I don't remember. Anyways, I'm going to use 60 as an example. So the patient was on 60 liters per minute
Of O2?
of oxygen on the Airvo with an FiO2 of 80%. So what that means is that every 10 we went up, we were adding 1 of PEEP. So his natural PEEP was 5. She added 60 liters per minute. So that means he is breathing with a PEEP of 11. And I thought that was really interesting. I never knew. Ever.
So either, I ain't never seen nobody on that much oxygen.
Oh, he was going bad.
Yeah, he wasn't
60
doing
liters.
every 10 liters per minute on an Airvo on the high flow or the heated high flow is 1 up in PEEP. Time is it? 1:30. Okay. So we already talked a lot about these terms, but we'll go over it again because I need you to be very familiar with these terms. Your tidal volume is the volume of gas or oxygen that is delivered with each breath. You don't have to be on a ventilator to have a tidal volume. Every time you breathe in, you are breathing in a volume. And that is measured in milliliters. FiO2 is the fraction of inspired oxygen. Oxygen concentration of air being delivered to a patient. Room air is 21%. You can go all the way up to 100%. I gave you a chart. There is a chart on Brightspace to determine your FiO2. On your exam, you will have to be able to figure out how much FiO2 your patient is receiving for your PF ratio. So if it says that your patient is on 6 liters, you have to be able to do that formula to be able to tell me the percentage of oxygen to properly find out your PF ratio. Okay, we'll look at that in a little bit.
The chart.
Okay. PEEP, positive end expiratory pressure. This is a pressure applied at the end of each expiration. This prevents alveolar. Important and must be at least 5. The frequency, which is your rate, this is the number of breaths per minute. IE ratio, this is the proportion of time set for inspiration and expiration. We don't do anything with that. That is very much respiratory therapy. We don't do IE ratio stuff. Pressure support is the push of air to assist the patient with a spontaneous breath. So this is like a little tickle, like, hey, don't you want to do this? Come on, come do this. Okay. When we talk about pressure alarms, there's 2 different pressure alarms. There's a high pressure and a low pressure. High pressure is, you would think that it would actually be, you would think that your high pressure alarm would be like the really crazy one, but it's actually, I mean, don't get me wrong, they're both important. but your low pressure alarm is actually the one that's like really crazy obnoxious. Your high pressure is that there's something blocking the tubing, whether it's secretion, mucus plug, coughing, gagging, fighting the vent, too much fluid in the lungs, a kink in the tubing. There is something in the mechanism of the tube, of the ET tube, of the lungs. Something is blocking the air from going in. Okay. And this can be mild all the way up to a full on mucus plug that your patient is hypoxic and unable to breathe. So this can be very minimal all the way up to very severe. Your low pressure alarm is your ventilator has become disconnected. Your patient is not breathing. There is nothing connected to the patient. Your patient has either self-extubated, they've disconnected from the circuit, their cuff is deflated, and there's air, a large amount of air leaking around the cuff. There's a break or opening in the valve of the tubing. Something is wrong. Something is disconnected. And that can be on the patient side all the way down to the vent side. So on your ventilator, the tubing connects to the vent also, and that can come disconnected. Okay. So you need to know the difference between high pressure and low pressure. Let's take a break. I need a break. I need something to wet my whistle. 10 minutes.
like if I add money on.
Okay. Has it been 10 minutes? Huh? Okay.
So y'all be chain smoking cigarettes and drinking coffee with the music blasting, because that'd be the only thing that'd keep the road safe. That's it. Like,
Okay. Let's get back to it. So, this slide is talking about the prevention of ventilator-associated pneumonia, which is shortened for VAP, VAP. These are things that we do that is part of our protocol to decrease the incidence of ventilator-associated pneumonia. So to keep the bed above 30 degrees, oral care with chlorhexidine is Q4. At every facility I've ever been at, Q4 oral care is the standard. Pressure ulcer prophylaxis. This includes Protonix, sometimes omeprazole, but Protonix is the one that comes IV. Because believe me, when you have a NG tube, or not NG, well, you could have an NG tube, an OG, which is an oral gastric tube, you do not want to be putting those little teeny tiny Protonix pearls down those tubes because they are a pain in the tuchus. They're so annoying and they all get stuck. So if you have a patient intubated and you have to, and even if you have to give Protonix in any way, shape, or form down a G tube and you have an IV, just ask for it to be switched to IV. It's very simple. Instead of fighting with the little teeny tiny beads that get stuck everywhere, clog your tube. Okay. Daily sedation vacation. This is very important for all sedated patients if it's possible. If the patient has a control over their anxiety and they're not like going crazy and their respiratory status is getting worse because of their anxiety and because they're fighting the ventilator, that would be a reason why you would kind of avoid a daily sedation vacation, because that anxiety and that fighting the ventilator is only going to work against them and make it worse. So when you start weaning your sedation, it's really important to talk to your patient, because the more aware they get, I mean, I can't imagine, truly, I can't imagine waking up being restrained to a bed with a tube in my throat, breathing for me, and waking up like that. Like, I truly cannot imagine it. So it's obvious, and I feel like to anybody, that you would be anxious in that situation.
Yeah.
So talking to your patient and saying, hey, like, this is the only way that we can be successful in extubation. I need you to calm down. I need you to be able to breathe calmly, as calm as you can, on this ventilator on your own so that we can get it out. Now, don't get wrong, you are going to have people that they won't listen. Their anxiety is through the roof. They are just going to go crazy every time that sedation is turned off. And then you're going to say, well, how are we supposed to extubate these people? And this is what we call pull and pray, and not in the way that you say it. Okay? Pull and pray means we turn off the sedation, we pull that tube, and we pray that they are strong enough to breathe on their own. Okay? And yes, there are some situations where you have to do that because they will not cooperate during a spontaneous breathing trial. Because remember, you cannot do a spontaneous breathing trial with sedation. Okay? DVT prophylaxis, this is really standard for anyone in the hospital. You guys know this by now. Your patients are going to be on heparin. They're going to be on Lovenox. They're going to have SCDs, especially in your intubated patients that are immobile. And if obviously, I hope this is obvious, Q2 turning. If your patient is sedated and on a ventilator, they are not moving. They are not able to offload by themselves. If ever in a million years I walk into an ICU and I go to look at your Braden score and you're telling me that your patient that's intubated and sedated has a Braden score of 19, I'm going to laugh in your face because that's impossible. Okay. Case study. Mr. Jones is a 19-year-old male who was in a motor vehicle collision yesterday. He sustained a fractured left radius and fractures to the ribs 4 through 7 on the left side. He was admitted to the trauma med-surg floor last night. This morning, he suddenly developed shortness of breath and chest tightness. He says, I feel like I can't take a deep breath and appears very anxious. What nursing assessments should be performed at this time? Listen to his lungs. Pulse ox. Vital signs. Assess respirations. What do you think is happening?
Like he has a hemo.
He broke something.
So what can happen with his fractured ribs? He has some type of pneumo or hemothorax. Okay. And is it open? Is it closed? It would be closed. We have no opening. We have no penetration. Okay. Well, we already answered this question, but you assess Mr. Jones to find his SpO2 is 90%. His respiratory rate is 32, heart rate is 108, blood pressure 117/72. You auscultate his lungs, but find that lung sounds are diminished and almost absent over the left upper lobe. Dude's got a pneumothorax, and it's going to turn into a tension pneumo pretty quickly. Okay. So you notify the provider who orders a stat chest x-ray. The chest x-ray confirms the patient has a moderate sized pneumothorax on the left side with no shifting, see that, of the mediastinum or trachea. Okay, so so can you see this line right here?
Yeah, that's where the lungs would have been.
You guys see that line right here? Online, my friends, online?
Yes.
Yes?
Yeah.
That I'm pointing to?
Yes.
Thank you.
Yes.
That, and my friends in person, this line right here, that is the collapsed lung. This is the collapsed lung. This whole space right here is air. This whole black space right here. That's all air. That's not supposed to be there. Okay? So this is our normal lung. It's fully expanded on our left side. Our heart is in the normal placement. Our trachea, there's no movement. Okay, everything.
Bottom of the fully expanded lung. So that I can like, cause I don't know what I'm looking at really for fully expanded. I understand the one that's collapsed, but
It's right here.
okay.
You want me to come over to your computer?
No, I see it on here. I was, because I counted up from those two little white lines at the bottom to see where you're playing.
Your ribs.
You said the air is on the outside, correct?
The air is all here within, between the lung and the rib cage, or in the thoracic cavity. This a whole black space right here. Do you see this line, this definitive line? Okay. So
It's easier for me if I look at the vasculature. Like if you look at it and you can see like there's vasculature on the one
Yeah,
side and then
you
the other
can
side.
see the white within the lung tissue. Yeah. Mm-hmm. Yeah, you can see the little branches, but you're not. So the provider determines the patient needs a chest tube placed. You gather supplies, set up the drainage system, and assist with placement of the chest tube on the left side. That was the right side. Anyways, what output would you expect to see on initial placement of Mr. Jones's chest tube? So at this point, we don't know if, because of the x-ray, we know that it's not lung tissue, but we don't know if it's air or blood. We just know that the lung is collapsed. We won't know. Yeah, until we put the test tube in. So that output. Ow, that hurt.
You would see bubbles,
I
right?
don't know what I just did. Hold on. Myself. No, I'm fine. Okay. So if this was just fluid, like serous fluid, you would see an output of like a clear yellow fluid. And that's what we call a pleural effusion. If it's blood, we're going to see blood. If it's air, we're probably going to see a mixture of like a small amount of that serous fluid because that's everywhere. That serous fluid is everywhere. That's our plasma, right? It's normal for some of it to come out, but a lot of that is going to be air when you have a classic pneumo with just air trapping. Okay. But right now, I don't know if it's a pneumothorax or a hemothorax. So if it is a hemothorax, because remember that fractured rib can cause both. It can cause a pneumo or a hemo, right? The rib fracture was listed on both of the causes. So if this is a hemothorax, would you expect a large amount of blood to come out, a small amount of blood?
A larger.
Depending on how much is bleeding, yeah. Because at first, sometimes when you first insert that tube, you're gonna have a huge output. When you do that hourly output, you're going to see what's continuously coming out after that initial emptying. Okay, so it would be maybe not normal, but like appropriate if it was a hemothorax that had, say, 400 mLs trapped, for when you put that chest tube in to have an immediate 300, 350 come out. That would be appropriate. Okay. It would not be appropriate if you came back an hour later and there was another 300. That would not be okay. Okay. So this is asking about the initial output.
You have to be in surgery to get that initial output.
Side. It is a sterile procedure, but you can do a sterile procedure at the bedside. Good question. So you secure the tube with an occlusive dressing and you place the drainage system at the foot of the bed. The provider orders the chest tube to be placed to water seal without suction. Describe how the water seal works.
The water seal controls like when they breathe, they're not getting like air going in, right? They're keeping
The water.
the water's keeping them from breathing.
We're talking, remember, when we're talking about wet suction, we have the water regulator, the suction regulator, and then we have the water seal chamber. The water seal chamber is on both the wet and dry suction. So go in give me more.
Okay. So it's like controlling, because when you're breathing,
It's not
air, keeping you from breathing in air.
Yes.
Okay.
The water
getting-
seal chamber is making sure that when you exhale, that air goes through the water and it bubbles. Okay? And it's going out. When you inhale, it ensures that you're not inhaling air from the outside.
Okay, yeah.
It's a one-way street, baby. Out is the only way. And that's why we have the intermittent bubbling. Make sense?
From the breathing.
From breathing, yes. Oh, I think this is, I'm pretty sure the blank version doesn't have any of this. And then it says label the chest tube. So, remember I told you that there's a little port at the top that you connect to your suction. That is that suction port. If you're looking at the picture where it says suction port at the top, that's where you connect your suction. The drainage container is always going to be between the patient and the suction. Okay, I can't make that clear enough. If it's not the number one rule, it's fighting for the number one rule. Okay, drainage system, it must be between the patient and the wall suction. You can never hook up the patient's chest tube coming out of their body to a wall suction. Or I'm pretty sure it was Brittany who said it, Brittany's point, up to a Neptune in the OR. Never, 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 never. Okay. So then you have your positive pressure release valve. This just releases pressure, just like a pressure cooker. Your water seal chamber, when every time you open a new drainage container, it's going to come up sealed from, thank you, Central Supply. And when you take it out of the box, it's going to come with a little container of sterile water. That little container of sterile water is what you fill your water seal chamber with. It comes with it. It is a set amount with that drainage container. You don't just fill it with some random sterile water bottle, okay? It comes with the bottle. You squirt it into the hole, into the water seal chamber, okay? And that is where you see if you have an air leak down in that chamber on the bottom. There is a little ball that floats up and down inside that water seal chamber, and it goes up and down with each inspiration and expiration. That's just a little something extra, okay? I told you you have that little kickstand, and it's like a Christmas tree stand. It's perpendicular. It's like a cross. It's just helping the drainage system to stay stable and doesn't fall over. And like I told you, there are some nurses that tape that thing to the floor. Okay. Needleless access port. It is not routine to get a collection off of your chest tube drainage. If you were to collect it, it would probably be on insertion where the physician, the surgical resident, whoever is placing that chest tube is going to get that initial culture if you need it. Okay, that is not routine, but there is an access port if necessary. Most of the time, 98% of the time, you're never going to use it. Inline connector, this is where you connect the tubing of the drainage to the tubing of the patient. So this is just a connection port. Multi-position hangers, it has a little thing where you can hang it on the bed. I wouldn't get into that routine where I'm hanging it places, but eventually, especially if this patient doesn't have bed rest orders, this patient's getting up and going to the bathroom. What do you expect him to carry it like a baby? Just walking around with his chest tube? No, it has like a briefcase handle that dude's gonna carry it with him to the bathroom, okay? And then we talked about the collection chamber. The first chamber fills up and then spills into the second. The second chamber fills up and then spills into the third, okay? You don't really have to change the drainage system unless A, it falls over and your collection output gets all screwed up, or if it's full. Those are really the only two indications that you have to change it. It's not like you have to change it every 24 hours. You know what I mean? Any questions, parts? The connector? Which connector?
Inline connector.
The inline connector? That's where, so if you look on, I'm looking at the screen. So on my left side, I can see the suction port where it says suction port. That's where your wall suction connects to the suction port. Then on the right side, that's where that tubing connects to the patient. So see how it kind of comes out and you have your patient tube clamp, your patient connector. This tube connects to that inline connector. Okay. Any other questions? Do we need to know no, I'm not going to make you label it for the exam. No. This is more, what I need you to know about chest tubes is what do you do if it gets pulled out? What do you do if there's more than 100 milliliters per hour output? Call somebody. What do you do when it gets removed? What do you want the patient to do?
Do the Valsalva.
Valsalva maneuver. What do you do if you lose your drainage system and you don't want to clamp it?
You put it in sterile.
You put it in sterile water. You create a water seal. Okay. What do you not do? You don't clamp it without a physician order. You don't milk it or strip the tubing.
Then you'll get crinkly skin.
How do you assess for a leak? Is bubbling good? Is bubbling bad? Continuous bubbling within the water seal chamber is bad. Intermittent, aka titling, bubbles in the water seal chamber is normal. Okay. This picture is more for when you see this in real life, that you recognize these things and you don't look stupid in front of your preceptor or the person that's orienting you. Before. Maybe I don't know everything about it. I don't know A through Z, but at least I've seen it and I can recognize what these things are.
Oh, when something's not right.
Yeah. So no, I'm not going to have you label parts of it. Hey, some people would, who knows?
Yeah.
When I was in nursing school, I had to label a drop of blood all the way through the heart. And there was a piece of paper that she made that was, I'm not kidding, like probably 10 feet long. And we had to, with our feet, go through, like step through the entire blood flow of the heart.
Ridiculous.
Yeah, that's just like.
It was actually pretty cool.
But I'm gonna say, but
It was pretty
I
cool.
probably remembered it too after that.
I sure did. All right. What safety considerations should you take for the tubing and the drainage system? Tape it to the floor. What did you say first? Below the yes, below the patient. You never want the chest tube above the insertion site. That's very important. What'd you say, Trinita?
In between the patient and the wall for patient and suction.
The drainage system is between the patient and the suction.
Make sure the stuff is not open.
What?
Forward stuff, right? If there's. no
Why is-
suction.
If it's ordered without suction,
Yeah.
that, yeah, it's not
In
on
this
suction.
case it is. Okay.
Oh, yeah, in this case, it did say without suction, correct. If it's ordered suction, then you need to check what level of suction it's at. Definitely inspecting the insertion site for signs of infection.
Your supplies.
Your supplies are in the room, you're ready for an emergency to happen.
Make sure.
Amen, make sure it's not clamped. You better make sure it's not clamped.
I would also.
Making sure you're communicating with your team that this patient has a chest tube. Yes, 100% yes. You know, patients touch things that they're not supposed to touch a lot. So when your patient sees a little clamp and they're like, "Oh, what does this do?" And they clamp themselves. I'm telling you, I guarantee it's happened. Mm. What assessments would you perform to monitor the effectiveness of the chest tube?
Breathing,
Monitor for sub-Q emphysema. Okay, Amy,
like
what'd you
if
say?
they're breathing, make sure they're not having any more shortness of breath.
Absolutely, yeah, their respirations, their vital signs,
That out.
pulse ox, the output, repeat chest x-rays to make sure the lung is still inflating. So progressively, when your patient has a chest tube, they will get serial chest x-rays at least every morning, at the very least. And you will be able to see the progression of the lung re-inflating. Yeah, basic signs and symptoms, make sure we're preventing attention pneumo. What should we expect when the lung is completely reinflated?
That's what I was just thinking about bubbling, right?
No more bubbling. So no more intermittent titling in the water seal chamber. And remember, that could mean something else too, is that something is obstructing the tubing. So don't assume that, oh, we're successful, this is great. Don't assume just because your bubbles have left, that would be a bad thing. Okay?
And I'm assuming the way to check if it's obstructed is to get an x-ray or.
If I had a patient where I thought, especially if it was early on in the chest tube journey, it's way too early for reinflation and my bubbling has ceased, I'm probably going to call a provider
Okay.
and say, hey, I don't think this chest tube is working properly. If I'm in the ICU, I'm walking down the hallway and grabbing either, if it's during the day, my intensivist, or I'm grabbing a resident to say, you need to come and look at this.
Okay, so that's beyond our scope to like check if it's obstructed, like.
I mean, they're probably, at that point, it's really on notification, because are they going to order a chest x-ray? I mean, is it something easy where it's just a kink in the tubing and I can just unkink it? You know? Then I would probably check that first, check the
Yeah.
tubing first. But if there was an actual obstruction within the catheter that's in the chest, there's nothing I can do about that. You note intermittent bubbling in the air leak chamber, aka the water seal chamber, and no output in the drainage chamber. The patient's lungs sound clear, though still slightly diminished in the left upper lobe. SpO2 has risen to 96% on 2 liters nasal cannula. 4 hours later, you are checking the chest tube system again and notice continuous bubbling in the water seal chamber, the air leak chamber. What could be the possible cause of an air leak? It got dislodged.
Why would his oxygen level go
Um,
up if it had a leak?
So you're saying, so you got to read it. It says the patient's lungs sound clear and they're 96% on 2 liters. Then you go back 4 hours later, right? So there was a 4-hour time period in between that 96% on 2 liters. Okay. So the tube could have been dislodged. There could be disconnection of the tubing or the system. Equipment failure, like there's a hole somewhere where it shouldn't be. And then possibly it could be that the pneumo has gotten worse. Okay. What should you do if you discover there is a hole in the drainage system tubing? Change out the system, baby. Easy peasy. There's a hole in your tubing. I'm getting a whole new system. Because all I have to do is either go to my supply closet or call Central Supply, walk down to Central Supply, get a new one, and change it out. Easy peasy. Okay. So you notice the connections have become loose, so you tighten them, which fixes the air leak. Later that evening, when turning the patient, the chest tube becomes accidentally dislodged from the patient's chest. What should your first nursing action be?
You need occlusive dressings and
Help me! No, I'm just kidding. You have your occlusive dressing, your petroleum dressing, and your gauze and your tape. So has it completely come out of the patient's chest? So let's play both sides. A, it comes completely out. And that's when you need to cover that up in your window dressing with your petroleum and your gauze
this might sound
with your
stupid,
3-way tape.
but can you show that
The tape?
like how you would tape it? Because I know
Yeah.
it's 3 ways, but what are you? If it's 3 sides, are you covering the whole thing? That's why I'm not
Just like
understanding.
That's okay. It's okay. We'll Google it. Google it. No, I said we will Google it. Look at it together. Okay. And then on the flip side, so maybe it's just a little dislodged, not completely removed. Probably I'm gonna call somebody. I'm gonna call my physician. I'm gonna tell him down the hall, hey, I know this came out a little bit. I need you to come check this. And they're probably gonna put in a stat chest x-ray. If my tubing becomes disconnected and my drainage canister, say my drainage canister got kicked and cracked. Somebody kicked it and it cracked. Sterile water at the bedside until you can get a new drainage system, because you don't want it just hanging out all willy-nilly out in the air. Okay. So let's This is a good picture of a 3-way dressing, a 3-sided occlusive dressing for an open pneumothorax. So you have your free edge here, and you have tape on 3 sides.
And the free edge could be on any side, correct?
Yeah, I think it should be the side facing down.
Okay.
Yeah. I feel like that's the most common way, if it is done any differently. So, and I think, is your patient moving? Are they walking? If they're standing upright, then it's probably more correct to have your window facing down. If they're staying in the bed immobile, maybe you would have it this way. Like you're opening on this side, right? Because that's gonna be your gravity,
Yeah,
that's the way you're facing. That's a good question. No, I think that's a great question. Yeah, no, I think that's a great question. I would never have it up. I would never have it facing up, I don't think. Yeah, that's a good point. Or what your arm putting down, it would close it off. But yeah, I just think that would just be, it would kind of defeat the purpose to go up. I think it should either go down or towards the bed if the patient is immobile. But I would say 90% of the time I'm going down.
Okay.
Maybe 90, maybe even more, like 98% of the time I'm going down. Yeah. Hey, patients do
What they want to do.
do what they do a lot of things they shouldn't be doing. Okay?
Thank you.
You're welcome. I would rather you see it.
That's what I said. I'd rather look dumb in here than look dumb when I'm actually
learning.
seeing it for the first time. Everyone's like, what do you mean?
I'd rather you be dumb here too.
I'm done.
Listen, I didn't know. She said 3 sides. I'm like, how are we doing that on that hole?
Okay. Hey, just because you were brave enough to ask doesn't mean there wasn't somebody on here that wasn't thinking the same thing. I would rather you look stupid here with me than you look stupid on the floor on your first job and you're like, oh yeah, I know what I'm talking about, and then you don't.
Yeah, that's why.
Okay.
Like,
All right.
yeah.
Create the nursing skills sheet for chest. What? What nursing skills sheet? We're just gonna skip over that. Okay. Mr. Jones remained stable even without the chest tube. Thank God. Thank the Lord, baby Jesus. Therefore, the provider decided that his pneumothorax had resolved and there was no need to replace it. You continue to monitor for any possible complications or redevelopment of a new pneumothorax. Mr. Jones is complaining of slight pain in his left side. What assessment would the nurse complete to get a better understanding of the patient's pain? This is basic. There's nothing special. This is basic pain assessment. Okay. Where? When? Does it get better with this? Does it get better with that? What is your pain on a scale of 1 to 10, 0 to 10? Okay. So this is your very, very normal pain assessment.
Now, it just.
Carl Shapiro?
No.
Oh, who? Oh, Vincent.
This,
This is Vincent?
yeah, all of the, got a pneumothorax.
So you probably should have waited to do your VSIM until after lecture.
I mean,
I did very mediocre. A consent? Yes. So that's a really good point. A chest tube insertion is a surgical procedure. If it is done under emergent situation, life-saving, it cannot wait. You do not say, hey, can you please wait to die and sign this?
Oh, right. 1 second.
Okay? That is a negative. The chest tube is being placed. Is family there, the next of kin? Hey, we're putting in a chest tube, right? There is a difference between life and death and, hey, you have a pneumothorax. I don't want you to get worse. We need to place a chest tube. These are blah, blah, these are the blah, blah, blah considerations. You need to sign the surgical consent, right? Two very different situations.
Yeah, so I got dated real bad to that because I forgot.
Maybe he's allergic to morphine. So remember when we're talking about our pain assessment, we have the PQRST, provoking, quality, radiation, severity, and timing. Is this normal, predictable pain after chest tube removal? You would think if you just pulled a tube out of your chest, that it would probably be a little sore. Okay. And also, he was in a MVA. He has 3 or 4 broken ribs. So he's going to be in pain. The difference is he in a normal amount of pain or is he in severe pain? Okay. So that's why pain assessment is so important. What medication can the nurse anticipate the physician ordering for mild chest pain? I mean, so back in the day, this slide says the answer is morphine, but back when I worked step down and we had a lot of transfers from SICU, we had a lot of chest tube patients. Our patients were on every 4 hours, they would get Tylenol and Robaxin. Robaxin is a muscle relaxer because if you think those intercostal muscles, those muscles between the ribs are really, really sore, especially if they were in an accident and they had trauma to the chest wall. So breathing, you want to make breathing as pain-free as possible for these patients. So morphine, absolutely. If they're in a lot of pain, severe pain, 7 out of 10 pain, definitely you're going to hit them with something a little heavier. But normally the physician is going to provide them with around the clock medication like a muscle relaxer and Tylenol. Depending on the patient, maybe some Toradol, probably not Motrin because they want to decrease the stress on the stomach. They also don't want to cause any more renal issues if there are renal issues. So usually Motrin is not given within the hospital. If you are giving an NSAID in the hospital, it's most likely going to be Toradol. And with Toradol, you even have to be careful with kidney function and all the things. So usually it's just going to be Tylenol and a muscle relaxer with then a PRN breakthrough pain reliever like morphine if they're in a lot of pain. If maybe even sometimes you would have maybe some PRN Norco. That has become popular, especially in the last like 10 years. Norco is very popular. Or PO oxycodone. Yeah. Okay. That's the last one. Okay, so it is it's 2:05. We do not have class on Monday, and then we have the exam Wednesday morning.
Oh my gosh.
I know, it's
I forgot.
crazy. Martin Luther King. The key points will be sent by Friday. Yes. So key points will be sent by Friday. Make sure your ATI exams A and B are done.
Sunday at 11:59.
Yeah. Get your, especially with having that extra Monday off, get these assignments done and out of the way.
What is due at 11?
Yeah. The ATI practice test. We can't talk about the exam because our person is going to be taking the exam after class today. But there will be EKGs interpretation on this exam. On this exam. And
ABG interpretation.
I'm sorry, ABG on EKG interpretation. EKG interpretation will be on this exam. I am very much looking forward to having an open conversation once we have all taken the exam about my feelings, because they're not great. My feelings are not great. So what I think and what I really truly believe is that I feel like you guys overstudied. I feel like you invested so much of yourselves into the EKGs that you got yourself to a point where you confused yourself. Because some of the mistakes that I saw were very much like, really? Really? So, I'm giving you another shot. So please expect to see EKGs on this second exam, and they will 100% be on your final. Okay? I need you to be able to interpret these rhythms. Okay? And once I can speak openly, I will say more things. One of these nights, maybe, I mean, does anybody have plans for Martin Luther King Day?
No.
Because I would totally be willing to have an exam overview on Monday. Like
I know
during
I'm
the day.
scheduled to work.
Huh?
I am scheduled to work.
Yeah, I'm
Can you take a break? She said. She said you gotta work. Yeah, Sarah, what time you work until? And no, I will
I work
never,
until 7:30 at night.
I will never in a million years ever, ever record an exam review. And if I ever catch someone else recording an exam review, I will remove you from this program as fast as you can say remove. Okay? It is never, ever going to be reported or
Not
recorded.
worth it, man.
There will not be as many. It will not going to be as, and remember, we cannot talk about a lot of exam stuff. I actually thought you were going that, oh no, said Tara. She said, I thought you were just doing EKG review. No, ma'am, I'm talking about exam review. Can the majority of people partake on Monday?
yes.
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 Yeah. Yes.
So I only have 2 people that are working on Monday. Is that correct? I need a yes or a no. Is it true that only 2 people are working on Monday?
That's what it sounds like.
That's what it sounds like. Does everybody agree? Okay, so for those guys, I need the side conversations to decrease. For those 2 people that are working on Monday, we can have like a one-on-one at a different time, or even both of you together, like a two-on-one kind of thing. If you got a CPT for the exam, we should be meeting individually for the exam, which all of you guys have already received that. So, and I'm gonna see if Brandy has any availability to go over the exam. So Sarah and Brittany, right? Those are my 2, Sarah and Brittany, that work on Monday. Huh?
Yeah,
Why?
I'm one of them.
At what time? What time? Okay, so now I got 3 people. So would like a 2 o'clock work on Monday?
Yeah, I'm pretty hard.
2 o'clock?
Yeah.
Yes,
Exam
that sounds
review
good.
on Monday, exam 1. And then my people that work, so I have Jackie, Brittany, and Sarah. 3 people. Yes?
Right.
Yes. Okay, so you 3, we will find a alternate solution.
My boss will let me take a break in the middle of the day to go to exam review, so I can probably attend that. I just have to let her know that it'll be at 2.
Okay. All right. So
I
then
know
I have a
Sarah,
question.
Sunday I'll be available after 4.
on what day?
Sunday, the 18th.
And you guys know I'm more than willing to do off days, but with my schedule getting so crazy and I have all this homework for my master's, I really need to prioritize my time. And I really need to try to be cognizant of where I'm using that time. So I'm going to really try not to, do like a weekend thing unless I have to, unless I have the time to do it. So Sarah, if
So I
Sarah
know. Okay.
and Jackie,
I
we can
understand
do
you not wanting to do it on Sunday. I'll be home by like 8 o'clock. Monday and
Monday.
Tuesday.
Okay. And we could always, because this is a exam 1 review, we could, I think I have, do I have clinical on Tuesday? Some of you guys have clinical on Tuesday.
Yeah.
No, just for me.
Yeah, but Lyria has, I think it's Illyria that has clinical on Tuesday also.
Oh, don't you guys have your makeup on Tuesday or the 20th?
Oh yeah, the 20th. Yeah. Okay, so Sarah, I'm gonna send you my link. We're gonna make a appointment and we'll go over your exam together. But other than that, we're gonna do a group review on Monday at 2 o'clock.
Okay, that works for me.
Okay.
I have a question.
Go ahead.
I made an appointment with you tomorrow at 2:30, but I have clinical until 3. But the last half an hour, we usually sit in the classroom and like do our packets. So, like, is that okay?
Yeah, that's totally fine. If your clinical instructor is okay with it, I'm fine with it. Also, I know that there have been some instances if you had downtime during your clinical day, that I have met with students during clinical. That is completely up to your clinical instructor if they will allow that. If they do, especially Friday, I'll be in office. So if anybody has an opportunity to meet, especially a CPT person, to meet on Friday and you have that downtime during clinical, just send me an email or have your clinical instructor text me and say, hey, Amy has free time. Can you meet her for her exam for the next 20 minutes? Yes, let's do it. Okay, so keep that in mind too. Yeah. Okay, PF ratio. I want to look at this because you guys are going to have to do this, be able to do this. Why don't you recognize my face? This is ridiculous.
Because I know what I did. It was just two stupid things I did, and I know how to do it. Like I'm in the bath. I just
Then that's
didn't round up.
that's okay. I mean, if you feel that way, then that's okay. That
Well, the one I didn't change to hours. All I had was 5 by 60, and the other one I just rounded to a whole number, which was stupid. So
okay. All right, let's look at this FiO2 and how to Okay, so use the FiO2 formula. FiO2 is the percentage of oxygen you breathe in, and we can estimate it using a simple formula. FiO2, now, okay. Remember, room air is 21%.
Well, I was gonna ask you about that. The paper says 20%.
I know.
Should be doing it by 21.
No.
Okay.
So remember, room air is always going to be 21. Okay? For your FiO2 formula, it is 20.
Okay.
Okay? So 20, and remember back in middle school we learned about PEMDAS, okay? You do the parentheses before anything else. PEMDAS, parentheses, PEMDAS. The D is for division. Okay. PEMDAS is parentheses, exponents, multiplication, division, addition, subtraction. That is the proper way to do math when you have different things in your math equation. So you always want to do your parentheses first. So we're looking at this. This is liters per minute times 4. So if your patient is on 6 liters, you would say 6 times 4 is 24. And then you would add 20. Okay. So it gives you an example of 2 liters. 2 times 4 is 8, plus 20 would give you 28% oxygen. So then if you were doing a PF ratio, you then have to put that into a decimal. So you would have to say 0.28. Okay? That makes sense? No? Okay. You're okay. So there's a couple examples on here. So if your flow rate is 5 liters, it would be 5 times 4, which is 20, plus 20 would be 40. So that would give you a 40% FiO2. And then if you're doing your PF ratio, it's the PaO2 divided by the FiO2. So say your PaO2 is 80, it would be 80 divided by 0.4. You must know this formula. It's a small one.
So you're just adding 20, you're not adding 20%.
No, you're adding 20.
Okay, because
Yeah.
that is what's confusing. All these percents.
Because, well, it is a percentage. The FiO2 is a percentage. So I think that's why,
Yeah.
But I understand in the equation, it does say the percentage after 20. So I do get that. But yes, you're just adding 20.
Okay.
So do you want to do some?
Yeah.
Yeah.
Do some practice?
Please.
Okay.
Yeah.
Please. All right. I don't know if there is a place to turn it in, to be honest with you.
Is it?
Oh, there is? Oh, okay, yeah, you have to turn it in.
Same thing as,
What the, what, no, no, no. Okay. You said it, it's on the grade book? ABG worksheet is on the grade book? If it's not on
I
the
don't
grade book,
see it in my
not adding it.
assignment. Asking if it's on the grade book, not in the assignments.
Okay.
Okay. Yeah, everybody calm down. There's a lot going on in here.
I don't have anything for burn.
The burn worksheet is in week 3.
There's only a worksheet for cardiac and a worksheet for. That's it. There's nothing else in the grade book for ABG.
Okay. All right. Let's just take a breath. Everybody just calm down a little bit. All right, let's do some ABGs. Oh, and it literally does say on the paper, must get an 8 out of 10, turn in on bright space. I don't care. Okay. All right, so. All right. So I have a pH. Guys, please stop. There's a lot of side conversations happening today, and it's really overwhelming and distracting, especially if it's distracting for me and I'm having trouble getting my words out. It's going to be more for them. And then it's going to sound even worse on the recording. Okay. All right. I have a pH of 7.18. So 7.18, I'm putting it on my left side.
Yeah. Sorry.
We have a CO2 of 50 on the acid side. My bicarb is 27.
Right.
Base, alkalotic side. Okay. So our interpretation is what?
Respiratory alkalosis.
With what compensation? Partial. Okay. So I have a PaO2 of 80 and I have an FiO2. What? Oh, of 32.
No, sorry, I mean,
You're fine. So that's 80 divided by 0.32, because remember we have to make it a decimal. Okay, so what is that? And what does that mean? So, but what does it mean on that chart where we're talking about oxygenation? They're not doing well. They're not doing well. Okay, so what is it? Over 400 is adequate, right? 300 to 400 is hypoxic.
So it's
2 to
ARDS.
300 is ARDS. Anything under 2 is critical. Okay. So at 250, we're in acute respiratory distress. We are distressful. Okay, so what do? Increase FiO2. We can also, because we're so alkalotic, and we don't know the vent setting, like 12, you could also increase the respiratory rate to try to blow off a little bit more CO2. Okay. But the key here with your interpretation and what do I do is I know that I'm not oxygenating great. My PaO2 is 80. Yuck, bad. Okay, so I need to increase my FiO2. All right, my next one. Ooh, that's a big box. That doesn't need to be that big. Okay, so my pH is 7.36. Normal. My CO2 is 42. My bicarb's 25. Hey. And we're on room air. We are a normal human. We are a normal oxygenating human. So this is a normal A, B, G. Also, what is our PF ratio? So we have 96 divided by 0.21. And that equals 457. So what do? Nothing. We don't need to do nothing. Solid. Okay. Whoop. All right. Number 3, we have a pH of 7.36. Normal. We have CO2 of 20. Bicarb is 21. What is my interpretation?
Fully compensated.
Compensate.
Is it metabolic acidosis?
And remember my rule of 4. So I'm leaning this way, right? And what's over here? My kidneys. So this is fully compensated metabolic acidosis. See how we got that?
No.
No.
Forget the rule.
The rule of 4?
Yeah.
So the rule of 4 is that the middle is the middle is 7.4. So if my pH is leaning toward alkalosis, then whatever's hanging out over here is going to win. So if this pH was 7.41, this would have been respiratory alkalosis. Okay. But because my pH is more towards the acid side and my bicarb is hanging out over here, so it's making this side heavier, this side wins, making it metabolic acidosis. Does that make sense to everyone? Online friends,
Yes.
please?
Yes, it does.
Thank you. Okay, so now we have our PF ratio. Our PaO2 is 98 and we're on 5 liters. So our formula is 20 plus 5 liters per minute times 4. So 5 times 4 is 20 plus 20 equals 40. And then we have to make it a decimal. So 98 divided by 0.4 is equal to what? 245. What'd you say, Latasha?
So anytime it's the leader involved, you have to do that equation.
Yes, every time you have leader involvement, you have to be able to do the formula to find the FiO2. If you're given the FiO2, you're good. You're golden. You already have it. You only have to do is make it a decimal. Okay? Oh my God, my knee. So even though this person is saturating okay, their PF ratio still sucks. And we still have metabolic acidosis. So in this situation, what do is, yes, our carbon dioxide was starting to compensate because it was out of range and our pH is normal. So our compensation is kicking in. We're fully compensated. But if this patient was ventilated, let's just say, if this patient was ventilated, the one thing we could do to help retain more CO2, or I'm sorry, to help the acidosis is that we could give bicarb, IV, sodium bicarbonate. That makes sense? Whether they're vented or not, actually, you can give bicarb for your acidosis.
I have a question.
Yeah.
Why do you have to push it like 5 to 7 minutes?
So you're
Because
talking about a sodium bicarb bolus, and that can be pushed because it's also it's hard to push, to be honest with you, to push a bolus of bicarb, but you can also have a bicarb drip. So someone can be on a bicarb drip at 125 milliliters per hour. It just depends on the patient. And the 125, I made that up. It could be at 50, it could be at 75. So you can either bolus bicarb by pushing it, or you can also give it as a drip. It's up to the physician. And it's hard to push. It's in this big, like when you're giving a bolus, it's in this glass, like big ampule thing. And it's just, it takes so much of strength to push it in. And I don't know why they make them that way. I really don't. So in this situation, you wouldn't really have to go up very much on your FiO2 because their saturations are okay. Their PaO2 is at 98. So it's not really about their oxygenation right now. It's really about their acid-base balance. If the patient continues to deteriorate because they're in acute respiratory failure because their PF ratio sucks, then you are going to have to go up on your FiO2. Because eventually, if you don't hit this fast enough and treat it fast enough and get this patient, say they have pneumonia, and this is why they're in this situation, we need to treat the underlying cause so they don't get worse and require more oxygenation. Okay. Do we want to do another one?
Can we do 5?
You want to do number 5? Yeah, let's do number 5. Okay, 7.24.
Acid.
CO2 is 45. Normal. Bicarb is 17. So what is this?
Metabolic acidosis.
Okay.
Partially
So our,
compensated.
it is uncompensated. Partial compensation has to be empty in the middle. So our PaO2 is 64, so it sucks. And we're on room air. So 64 divided by 0.21 equals 304. This patient is severely hypoxic and needs to increase the FiO2. This one, let's do number 6 because this is a good one. This is the first time we've seen a PaO2 over 100. So our pH is 7.42. CO2 is 30. Bicarb is 12. Which way is my pH leaning?
The alkalotic side.
Okay. So my PF ratio is 158. And my patient is on 100% FiO2. That's bad. That's bad. I can't go up on my FiO2. It's already at 100%. So what can I do? I can increase my PEEP. Okay. We have respiratory alkalosis. Decrease respiratory rate. I'm not touching that vent.
Right, so
Hex, yeah. Yeah. And this, the key is here is that you're able to interpret it. The interpretation and expectation. So you're able to expect orders. Not expect orders. What's the word? Anticipate. Thank you. You're able to anticipate orders. So you can see your blood gas and you can go to your provider and say, hey, this patient is tachypnic and anxious on the vent, and their respiratory rate's 47. So number one, how do I decrease my rate in my anxious patient? Increase sedation. Now, if they're fully ventilator dependent and their rate is set at 18 and they're showing alkalosis, then you can have them reduce the rate, like you can have an order to reduce the rate from 18 to 14 and help retain a little bit more CO2, right? But if we're talking about a patient that's breathing spontaneously and anxious and tachypnic, which is causing the respiratory alkalosis, then you need to increase your sedation. So that's a good one. That was a really good one. Okay, now what?
So we're still turning this in now.
I don't know. Do you want to just do them all together? I, yeah, you really shouldn't have said that was mean. I'm offended now. But I need you guys to be able to figure these things, to do this formula and be able to do this correctly. Number 7. So I'm pretty sure I came up last term with a second ABG worksheet because I think we ended up doing the same thing and like doing most of these together. And I think they asked for a secondary worksheet. So, and even if I can make one. So number 7, we got a pH of 7.41. I got a CO2 of 27. And I got a bicarb of 16. Oh, I put that in the wrong place. Okay, so what is this? Okay, so my PaO2 is 164. And my FiO2 is 71%, so that's 0.71. So what is my PF ratio? 231. Okay. So
I guess mine are more like, would you do the same thing, like decrease their respiration?
so we are having some respiratory alkalosis. We could decrease the respirations and increase sedation. We could no. PEEP is only increased when you have refractory hypoxemia.
Okay.
Because we have respiratory alkalosis. Where is? Okay. All right. Is there anything else you guys want to go over before we call it quits?
I was gonna have a quick question. Do you have by chance any extra EKG strip things so I can try to practice those?
I do not think I do actually. There are so many EKG practice sites. Honestly, because that would take me. I mean, I could try
If
to
you
make a
throw
new
out a
one.
website, I can go there and
Um,
look. I just wanted some extra ones because I don't do very good on them.
Oh, I don't even know. Registered nurse RN has them. So yeah, I mean, even if you go to Google and you type in EKG practice strips, um, there's a bunch of stuff that comes out. There's Quizlets, the ACLS medical training, EKG Academy. There's a bunch of videos. Oh, this one's good. This one, let me share this one. I just sent a practice. I don't know if it gets really in depth because it says it's ACLS. So okay. Did you see that, Amy, that I shared in the chat?
Yep, thank you.
All right. Rutney, are you staying? Okay. All right. Anybody else have any questions for me?
Yeah, so you just want us to finish filling this out and just email it to you, or you'll just upload a slot for us to upload it?
I'm gonna put something on Brightspace for you to upload it.
Okay, thank you.
Mm-hmm.
I sent you an email. It doesn't have nothing to do with lecture.
Who was that?
Can't tell.
Chantel?
Yeah,
Okay.
but
I will go look at it.
okay, thank you.
You're welcome. All right. If you don't have any questions, you're good to go. Thank you. Have a
Thank
good day.
you.
You're welcome. You too.
CPT is scheduled tomorrow at 1:30. Did you want me to keep it at that time, or do you like a later time, like 1:30?
I'll be back here by 1:30. Yeah. Yeah. For metabolic. Yeah, metabolic alkalosis. Is that what you're saying? Or acidosis? But I want to answer questions. She said, yeah.
Like like that to determine that CPT. Now I'm like on what to do for each one. I think maybe that's maybe that's what, oh, I don't know if they know what the metabolic alkalosis either, right? For acidosis.
I might send out like a little something extra to help with that.